الصحة والجد. Test. Assalamu alaikum wa rahmatullahi wa barakatuh. Distinguished guests, esteemed colleagues, and passionate healthcare professionals. May the peace, blessing, and the mercy of God be upon you. It's my great pleasure to welcome you all to the second day of the World Health Exhibition. As we gather here today, we are united by our shared commitment to advancing global healthcare and shaping the future of healthcare. The challenges we face in healthcare are complex and ever-evolving, but so to our talents, to our resolution to these challenges. Today, we have an extraordinary lineup of speakers and sessions that promotes, inspire, educate, and ignite meaningful discussions and partnerships. From cutting-edge technologies in healthcare, to healthcare policy, to healthcare education, let us approach this day with an open mind and to be ready to learn from one another and establish new partnerships to evolve the new era of healthcare. So, ladies and gentlemen, without further ado, let us begin our journey. By introducing Sir Harry, who will speak to us today about the Right Touch regulation, which aims to optimizing regulations in healthcare. So, without further ado, we are honored to have Sir Harry Carrington to the stage.
Assalamu alaikum. I'm so honored to be here with you today and to be working with the Saudi Commission for Health Specialties as an advisor. I'm going to talk this morning, or perhaps we should say just this afternoon, about right touch regulation and the importance of health professional regulation in improving health systems. Right touch regulation is a concept developed first in the United Kingdom by the Professional Standards Authority, but subsequently taken up by professional regulators across the world, including very much in Canada, Australia, New Zealand, Ireland, Hong Kong, and now I'm very pleased to say Saudi Arabia is leading the way. So, what is right touch regulation? I'm looking, I now have a clicker. Right touch regulation is based on a proper evaluation of risk. It's proportionate, it's outcome focused, and it creates a framework in which professionalism can flourish and organizations can be excellent. And I stress the word professionalism because right touch regulation is regulation that supports health professionals to do their jobs to the best of their ability. It's not regulation that restrains, it's not regulation that punishes, it's not regulation that is full of rules that you can't follow. It's regulation that lifts up people's professionalism and frees them to be good. And we use the word excellence at the end of that first sentence. Excellence is a very difficult concept in some ways. And I think it's important to stress that in right touch regulation, we see excellence not as an outcome, as an end, but as a journey. Excellence is a process. It's how we do things, not what we achieve as the final result. So being excellent is an activity, not a destination. And that's an important underlying piece of thinking. Right touch regulation is about balance. And I want to stress this as much as I can. If we take that little image of an old-fashioned set of scales, I expect you all have digital scales now, but I have some scales like that at home, which I inherited from my father. And they're very nice to play with. And the thing about those sort of scales is when you put the flour or the sugar or whatever it is in one balance, it goes down. And then you want the weight in, and you're trying to get the scales to balance. And if there's too much flour, then the scale looks like that. If there's not enough, it looks like that. And what we're trying to achieve in right touch regulation is the balance of regulatory force to ensure that we are using just enough regulation to achieve what we want, and not too little, because too little won't work, and not too much, because that's a waste of effort. So we're really trying to ensure that we have balance. And you'll find when I talk a bit more about what right touch thinking is, it's often balance in our decision making, balance in our use of resources, balance in our understanding of people, balance in our understanding of risk. All these things are fundamental concepts in right touch regulation. So there are 8 principles of right touch regulation. They're fairly simple steps that we should take when we are deciding whether or not to regulate. But they're also a good guide for all our organizational thinking. And the first step is always identify the problem before the solution. I'm sure you all know the experience of going into a meeting and someone says, we've got a problem to solve, and immediately 3 people suggest solutions. And you've never discussed the problem, you've only jumped to a solution before you've analyzed the problem. And yet in healthcare, we analyze problems all the time. We look beyond the symptoms of a condition in order to find its cause. And in right touch regulation, we need to do the same. We need to look beyond the symptoms of the problem to the cause of the problem. And we need to aim our regulatory activity at the cause and not at the symptom. The second principle is to quantify and qualify the risks. Now, risk assessment is something that we are often very lax about. So we jump to decisions about risk in the same way that we jump to decisions about the problem we're trying to solve. There can be risks which are minor but very common. There can be risks that are severe but very rare. And we often can't find the right balance between how do we respond to risks that might be very severe or risks that are common but very minor. Where should we put our effort? Where should we put our effort in healthcare, for instance, worrying about population risks compared with individual risks? Let me give you a few examples of the difficulty of deciding about where to place your effort on risk. A few years ago, the Chief Medical Officer in the UK asked me to chair a review of cosmetic practice and to try and work out where the risks lay and whether there should be more regulation. And during our deliberations, which was just after the time when in the UK we'd had an outbreak of BSE, or bovine spongiform encephalopathy, and there was a lot of panic going on about whether BSE could be transmitted to humans through Creutzfeldt-Jakob's disease. And we found, of course, that many people who had dermal fillers injected into their faces were using dermal fillers that had collagen in it. And collagen, of course, is made from cows' hooves. So there was a theoretical risk that BSE, CJD could be transmitted through collagen. It was only a theoretical risk. But when we included that in our report, of course, the newspapers and the media were very excited. And all the headlines were not about what we were doing to help make cosmetic practice safe, but what the risk was of getting CJD. Now that was a disproportionate, that was an unbalanced response to a risk, because I can tell you that over the 20 years or more since that report came out, there is, to my knowledge, not a single case in the world of CJD arising from someone who had a collagen injection. So we need to decide when we're analysing risks just what happens and what really we need to do to intervene. The third principle is get as close to the problem as possible. Regulators sit, if I may say so, in ivory towers. They are in offices away from the front line of healthcare. And they often work through expert committees who are some of the best people in the profession. And the best people write standards which are so high, so complex, so difficult to meet, that ordinary health professionals on the front line, in a busy ward, in an operating theatre, having to make decisions there and then, in the moment, are disadvantaged by those standards and can't meet them. So we want standards that are as close to the real world that people work in. Let me tell you another story. I was working with some clinical directors in hospitals, and I asked them to share with me and with each other some real examples of situations that had gone dangerously wrong and whether more regulation would have made any difference. And two nurses told me a story of a child who had cancer and who was in hospital and had a drip. And this child needed the drip changed in the middle of the night. And it was dark. And he was asleep. The regulations said that two nurses should go in together and change the drip. But they didn't want to wake him up. So one nurse went in, and one nurse stood in the doorway of the ward to watch. And the nurse who went in changed the drip, but it was dark, they didn't want to turn the light on, and she made a mistake, and she got the 2 tubes the wrong way round. Now that could have been a really serious clinical error. Fortunately, the nurse at the door went in herself afterwards and checked, found the error. Between them, they corrected it. But these were 2 people in the real world doing what they believed was the right thing. Yes, they slightly broke the rules, but they were working in the real world, and the rules were perhaps not helpful. And when we talked about it and said, could regulation have made a difference? The only thing they could come up with, but which was sensible, was maybe that the color coding on the drip tubes could have been luminescent, so they could have been seen at night more easily than it was. And that's the kind of thing that right touch regulation would do, thinking always about the reality of the circumstances in which health professionals have to make decisions. The 4th principle is focus on the outcome. Right touch regulation is interested in outcomes, it's not interested in process. It's interested in delivering change for people, not just in making people follow rules. So think about what you're trying to achieve rather than how you're going to do it. And someone asked me yesterday, where do you start with right touch regulation? And I said, you start at the end. You don't start at the beginning. You start at what you want to achieve, not where you're going to go. 5th, use regulation only when necessary. Regulation is a blunt instrument. It's expensive, it's time-consuming, it's elaborate. There are lots and lots of safety changes that you can make in healthcare practice that don't require regulation. And many of them, some of them will be here in this exhibition over the next day or so. There are many of the innovations in patient safety have come not from regulation, but from hospitals creating their own safety programs and being focused on clinical practice there and then. So regulation shouldn't intervene when there are alternative approaches, particularly of trusting professionals to do their job properly. 6th, keep it simple. I can't say that often enough. If you can't, as a regulator, if you can't explain your regulations to a frontline practitioner, how do you expect them to understand them and put them into practice? There's a great deal of what I would call, from that old film title, lost in translation. So you say to the regulator, oh, we took lots of advice from lots of real practitioners, and then you say to the practitioners, what do you think of those regulations? And they say, we can't put that into practice, it doesn't work in the real world. Somehow the regulation has been lost in translation. Then 7th, check for unintended consequences. Now we're trying, in health professional regulation, we're trying to change people's behavior. People don't like having their behavior changed. People resist change. And so it's naive to think that if you tell people to do something differently, they will. Or that if you set a rule, they will always follow it. I like to say that the worst regulators that I know are your IT managers. Now, you don't necessarily think of IT managers as regulators, but I can tell you they make rules that we have to live by. They say to us, you must change your password every 3 months. And I say, where's the evidence? And they say, it's good practice. And I say, that's not evidence, where's the evidence? Where's the evidence that 3 months is better than 6 months? Or that 3 months is good enough rather than 1 month? They don't have the evidence. What do? We don't like changing our passwords every 3 months, so we write our password on a little yellow sticky note and we put it on our computer screen. Or if we're frightened of our IT manager, we write it on a little yellow sticky note and we put it in the top drawer of our desk. So we are always trying to get round the rules. And you'll find that in unintended consequences, people try to get round the rules. So when you develop a new regulation of some kind, you should always think, how would people put this into practice? Would it really work in the real world? When I was an advisor to our health minister in the UK, there used to be a bit of a joke about our civil servants, and I would come forward with a plan of something I thought would improve healthcare, and they'd say to me, yes, Harry, we can see that would work in practice, but would it work in theory? So I think we have to be sure that what we do works in practice. And finally, in right touch regulation, regulators should always be ready to review their own work and to respond to change. Regulators like to tell professionals to have reflective practice. They like to tell professionals to do continuing professional development, to keep up to date. But of all the organizations I know, regulators around the world are sometimes the least likely themselves to have reflective practice, the least likely themselves to keep up to date. So always review and respond to change. So the first law of right touch regulation, and you'll be pleased to know there is only one law, because I like to keep it simple. The one law of right touch regulation is use only the regulatory force necessary to achieve the desired effect. Too much force is a weight of effort, too little won't have the effect that you want. So what are the problems that we're trying to solve in our health systems at the moment, and how can regulation contribute to the problem? Our first mission, of course, is to prevent harm. First, do no harm is the Hippocratic Oath. Second, of course, we want to do good. But the main task of regulation is to prevent harm. And we all know that our health systems are inadequate to meet contemporary needs. The second is every country in the world faces aging populations. And if you think the aging population is somebody else, I'm sorry to have to remind you that it's actually you. Everyone in this room is the aging population. I've actually got there myself at last. I'm officially defined by the British government as an old person, an elder. I don't feel like it. I'm still enjoying traveling the world and working and meeting people, but I am the aging population. I'm also a bit afraid of being called a demographic time bomb, because that's another piece of nonsense that we hear. The population has been aging in all countries, or nearly all countries, for many, many years. For over 50 years, life expectancy has been growing. Only in a very few countries now is life expectancy going down again. So it's not a time bomb, it's not a surprise, it's not something we haven't known about. It's something we should have been planning for the last 30 years or more. Thirdly, we have long-term conditions, increasing in number, diabetes becoming a major problem across the world, arthritis, and then mental conditions such as Alzheimer's and dementia and Parkinson's disease. All these things are becoming much more prevalent in the older population. I was talking to a director of nursing in one of the universities in the UK, and he said that all the young people who came in to nursing would say, and he'd say to them, "What do you want to do in nursing?" And they'd say, "I'd like to do pediatric nursing." And he'd say to them, "Well, welcome to geriatric nursing, because that's what you're going to be doing." And I think we need to recognize too that people have multiple long-term conditions. One of the issues about specialties and about the model of regulation that sees health professional expertise as individual rather than teamwork is that people have multiple long-term conditions. People with dementia have arthritis. People with dementia have hearing loss. People with arthritis have mental health problems. So you can't segment the conditions that people have into classified conditions. You have to talk about the person. And I know from my experience here that that is a value in Islam which I've already recognized and learned from working with the Saudi Commission. We also face risk of pandemics. We've been through the COVID pandemic. It's had a huge impact on society, on healthcare, on economic, on the health professionals. But there will be more pandemics. Everyone says there will be more pandemics. So please, let's plan for the next pandemic, and let's recognize it's a future problem. We have increasing cost of health technologies, and I would include in that medicines, of course. And again, you know, in the exhibition outside, there are some glorious and wonderful, shiny new bits of health technology, which will cost you a fortune. Our health minister just this week in the UK has announced that we're going to have a digital health service. He is, to my knowledge, the third health minister over 25 years who has announced we're going to have a digital health service. But it's much harder to do than it actually is to plan or to think about. So we need to absorb technologies. We need to make technologies our servant and not our master. We have a global shortage of health workers. Again, one of the things I know that's happening here and across the nations around the Gulf is, of course, to have more flexibility, more mobility for health professionals, the opportunity for more people to work in different countries. And that's an important thing to achieve. And finally, perhaps matching the first of these bullet points, we have growing health inequalities. In wealthy nations, we have growing health inequalities, which is a problem that we probably didn't envisage. But what is happening is that the well-off are able to buy a higher level and a higher quality of healthcare than the poorer. And this is particularly extreme in the United States, where there are some people who have no provision of healthcare at all, except through charitable services, and others who, of course, have the best possible health care in the world. I want just to remind you that the World Health Organization has just published an important paper. I think if I go back, if you look on the left-hand slide of this slide, that shows the cover of the World Health Organization publication, Health Practitioner Regulation, Design, Reform and Implementation. And this paper was just published formally last month. It's a really important guide. It's primarily aimed at small and middle income countries, but it's the best analysis of international approaches to regulation that I've ever seen. And in this, they set out key policy considerations, which I would strongly encourage anyone who's thinking about regulatory policy to take account of. Making sure that you have the core functions of a regulatory framework. And we're going to hear later this afternoon here about the work that the Saudi Commission is doing on examinations, on setting standards, on improving education. These are the building blocks of a good regulatory system. They talk about the importance of support for regulation from the health system itself, particularly the provision of data. Data is so important, as we know, in health care, and data should be used more than it is at the moment in formulating regulatory policy. They talk about the design principles. First and foremost, that regulation should serve the public interest. Second, that it should be proportionate, balanced. Thirdly, that it should be flexible in emergencies. We've seen how heroic health workers rose to the challenges of COVID, and we are seeing now how heroic health workers in Jordan, in Gaza, in Ukraine are also rising to the challenge, and that's a situation which no regulator can make rules for. That's a situation in which we can only rely on the humanity and the professionalism of the workers and not think that regulators can require them to follow rules apart from their skill and their heart and their belief. And finally, they remind us that we should think about governance. How do we manage our regulatory systems? And they recommend an umbrella law and an institutional structure, again, something which Saudi Arabia is creating. So I think that the work of the World Health Organization in this area, very recent and very much to be welcomed. And they identify what they call the regulatory practice gap. And I would like to suggest that right touch regulation can help close that gap. And what they mean by that gap is the difference between what the regulators say health professionals should be doing and what health professionals are actually doing. And that goes back to my point about regulation being disconnected very often from the realities of practice. So if you want to assess your regulatory gap, you have to understand the social and environmental context in which people work, and there's a great deal there which I think is very interesting, and I should declare an interest. I was the independent assessor on this piece of work by WHO, but one of the things I pushed them to think more about was the cultural differences that should affect regulation. How do you regulate, say, Ayurvedic medicine in India or in those countries? How do you regulate traditional Chinese medicine? How do you take account of Islamic values as opposed to other values in other countries with other religions and belief systems? So I don't want regulation to become another form of colonialism. I don't want imposing Western styles of regulation on other countries. I want people to build from the bottom, as I said before, to see what you're trying to achieve and find the vision to achieve it in your own situation. And develop and test improved regulatory interventions. Again, something the Saudi Commission is doing. So I commend this document to you. I spoke to WHO representatives last week and got permission to share this with you, but it's available on WHO's website, and I hope you will look at it. So finally, really, I just want to tell you what right touch regulation potentially can achieve against those challenges. It can help improve the safety and quality of healthcare, something we all want. It can improve the supply of health workers by reducing barriers, not by increasing them. It can increase the mobility of health workers by having shared values, shared standards, and shared training. It can improve the diversity of health workers by opening up the professions to a wider range of people. It can reduce the cost of healthcare because over-regulation is burdensome. Right touch regulation is not. So we want to reduce the cost of healthcare, and it can encourage innovation in the workforce. So I conclude really just by saying I believe right touch regulation is one of the tools, only one, but one tool we have to improve our health systems and to improve our support for the professionalism of health workers. I believe that the vision, the research they're doing, the dedication they're doing for in the Saudi Commission will bring about the kinds of improvements that we all want to see, inshallah. So thank you very, very much. I can have 1 minute for questions. So that seems like one question. Oh, there's no, your time's up. Oh, I'll take one. I'll take one question from you. Have we got a microphone? A microphone is on its way. Front row here.
Hello. So I just have one question from a different perspective. How do you see that we can implement the right regulation or the right touch regulation within the CPD frameworks and within the self-directed learning, and how we ensure that this is embedded within that?
So I think my first point would be to make the point about outcomes. So CPD tends to be an input. We expect professionals to do a certain number of hours a year. What we need to do is measure the outcome. So we need to find a way of ensuring that CPD makes a difference. Some CPD does make a difference, but we don't always know that it does. So we need to improve our ability to measure. And when we measure, we can then reduce the amount of CPD people do, take away the things that don't work, and spend more time on the things that do work. But otherwise, people, I mean, in the UK, it's got ridiculous. Doctors are spending hours a year filling forms in to tell the regulator what they've done. Well, I don't think that's very helpful. And I go to a lot of conferences. If I go to a nursing conference, I get a certificate saying I've got CPD points. Well, I'm not a nurse. I've got CPD points for dentistry. I've got CPD points for going to loads of conferences all around the world. I've no idea what that's about. So I think we need to refine CPD. I think it's very important, but we need to focus on the outcome and on training that we know makes a difference.
I think it's all about finding the balance, as you mentioned earlier. Thank you very much.
Thank you very much. Thank you, everybody, very much.
Thank you for sharing your expertise in this crucial matter. Ladies and gentlemen, we will move to our second session of the day, and it's an exciting one. The session titles Beyond Borders, in which an experience of non-Saudi trainers. We are excited to welcome Dr. Yasmin with us on stage. Dr. Al-Jazi, Shazia, blessing to you, and sorry for mispronouncing your name 3 times, but you can correct everybody. Thank you so much.
Hello, assalamu alaikum, good afternoon, and welcome everybody, and thank you very much for the Saudi Council for giving us the opportunity to talk about my experience as a non-Saudi trainer in the Saudi Council. So this is a very exciting talk, a very unusual one as well, and I was delighted when your team contacted us. My background is I'm working in Dr. Sulaiman Al-Habib Medical Group as a training program director for OB/GYN residency training since 2018. My journey with the Saudi Council began way before, because I came to Saudi from the UK, from the NHS system, back in 2009. So I have been a department head for about a decade before I changed the perspective and went into teaching. And there has been a lot of help from the Saudi Council, from our hospital group, and also from the peers in the training program, especially for the OB/GYN residency, that I would love to share some great moments with, and with a brief bit of a background of what we are doing at Sulaiman Al-Habib, because we are the first private healthcare group in the kingdom who have the ability of starting not 1, not 2, but 80 clinical programs with the Saudi Council, and which are running successfully since 2017. So our vision at Dr. Sulaiman Al-Habib is to be the leaders in healthcare education in the private system, and we develop our trainees not only to become diverse, but also to become culturally amalgamate in between the societies over here, and prepare them to go out in the country, in the region, in the world as not only as a trainer, not only as a collaborator, not only as a researcher, but overall a medical expert, as per the views of the Saudi Med, which has been translated into the Saudi training system by the CanMed system from Canada. So we have an excellent research center. We do an annual academic awards on an annual basis. Our research rewards are in excess of about 700,000 riyals, which get divided into the first, second, and the third researches. And we have a huge postgraduate training center. We have talent developing center, and our online academic forum has more than 800 different courses free of cost for all our trainees who are in attendance. So this is a brief journey. We began in 2014, and in 2018 we added more programs, and that's where we started our journey. And in 2024 we have advanced laparoscopic bariatric surgery. We have fellowships in and across the country and outside the country, as far as Canada and North America as well, which I'm going to touch base briefly with. We have institutional accreditation for Sulaiman Al Habib Medical Group by the JCIA 5 times now, and we have the local Sibahi accreditation for Sulaiman Al Habib Medical Group for 6 times. So that puts the things into perspective when we were talking about CPDs and we were talking about quality and safety. So all that is amalgamated into our trainees when we talk about giving them a good hands-on experience about maternity dashboards or about KPIs or about actually being part of the training committees and the committees for safety and quality in the hospital as well. So Sulaiman Al Habib Virtual Academy, we have more than 7,000 employees per hospital system, and we have about 13 hospital systems, so you can do the maths. So it's a huge medical group. It's like something akin to Kaiser Permanente in the US or any bigger institution, I would say, especially in Gulf region and in Saudi Arabia. It's one of the biggest private healthcare providers. So as the Saudi Council says, this is our program structure. We do morbidity and mortality committees, we do training and safety committees, we do grand rounds, we do half days of training education on a weekly basis, and we have mock exams, we have simulation training. As I'm here, the new residents who have joined from the 1st of October, they are doing a surgical training skills course on site at the moment as we are talking. And we also emphasize a lot on quality improvement. I have been the quality and safety administrator for the hospital group for about 10 years now. So there's a lot that we have amalgamated in the training practice of the residents in terms of safety and quality. So, and the program structure is, as the Saudi Council would say, that it would translate down from the program director to the deputy program director to the training directors, and we have institutional committees who meet on a 3-monthly basis, and we put our findings down, and we are very much sort of an interactive group. We are very much approachable group, and our trainees are working hand in hand with us in sorting out these sort of trainee-led committees. So it's not all about the top tier, it's about the ground level staff, our trainees who are involved in these committees as well. So yeah, that was a very exciting thing that I was being asked, what are my challenges as a non-Saudi trainer. Now, being part of this country since more than a decade, about 16 years now, I no longer consider myself as non-Saudi. Saudi is my second home. But yes, when I go back to the UK and when I compare, the first time I came here in 2009, and I came from the NHS very fresh. And what I thought over here was that in terms of safety and quality, I think we are more safer over here. I felt more safer as a foreign consultant with very little knowledge of the local language. So the first thing I would like to talk about is the language barrier that I had, that we, in our hospital group, we were very, very gregarious and friendly. We were given translators, and it took about 10 months to fly solo. After that, I asked my interpreter to stay outside and let me see how it goes. So it's not rocket science. Arabic is a very easy language to learn if anybody wants to learn it. And then again, embracing the change. I mean, if you are accepting the residents, of which we have 27 OB-GYN residents at the moment, and overall in our hospital at the moment, there are 92 residents from different principles, including medicine, including general surgery, including ICU, radiology, dentistry, so on and so forth. So it was very important to go down on the ground level to see what are the issues of diversity, what are the issues of difference in training from where I was coming from, and the difference in training what we have over here, and how we can mash them and marry them together to bring a unique program for our trainees. And then again, as I said, it's very much interactive training. It's very much like there is no tier system or no sort of system where we say that this thing is a commandment and this must not be done. The most important thing is that it's a learning curve. It is adult learning, and we do understand that adult learning can be challenging at times, but with simulation trainings, with the e-portfolios that the residents have to maintain, and with the trainers on site who are very, very important to be the part of the system, and with an overall scenario of all the trainers and training program directors and deputy training program directors in Riyadh, we are now a small family within this context. So that is very amazing how things took the turn for the positive from the very beginning, that I'm very happy to conclude that there has been not much issues at the ground level that we would have faced that would say that, okay, this is a big speed breaker and we need to take a look back and reflect on what we are doing. So we did not come across that many because we were given a strong foundation. And I'm so proud to mention our Saudi residents that who are coming from an education system, from the medical schools, that they are learning diversity. They are learning how to tackle racial disparity. They are also learning how to tackle safety and quality at work. They are learning how to be good communicators, and they are learning how to be effective collaborators at work as well. So that makes our job very easy on site. Okay, so basically, you know, we were initially, I had to learn the customs and norms. The first time I came from UK, and you know, what I learned was that, you know, you are a very, very friendly society. I have worked in different parts of the world. I have worked in the US, I have worked in Ireland, and I have worked in the UK. And then I came to Saudi. So comparing all four societies, I can say you are a very, very friendly and giving society. So you welcomed me with open arms, and I thank you all for that. And then, again, adapting the teaching styles. You know, I mean, there is so much to learn from these young learners as well. So what we do is when we are training a workshop, what we do is we sit together and we ask, you know, what sort of learning objectives are we looking into? So we have been about 6 years, 7 years into training now. So we have sort of these workshops in a box, which we can pull out anytime every 3 to 4 months. And then we can set it up at a very short notice as well. So here you can see some photos from our department where the residents are learning hands-on training for suturing, for episiotomy, and those kind of courses. Okay, and of course it was imperative to learn about the Saudi healthcare system and what are the differences between where I was coming from and what the Saudi healthcare system has to offer. And to my utter and pleasant surprise, we had a lot more to offer over here, and which I also learned as a trainer as well. So initially, when we started our journey, it was like a training of trainer course. I had already done one with the Royal College in London, and I did another one in Saudi over here, and that gave me the perspective of the salient, very, very special differences in terms of the societal cultures, in terms of the diversity, in terms of the understanding and acceptability of the cultural and the norms over here. And then, of course, comes the residency training matrix. It was slightly different from what I was used to, but not very different at all. It is more robust. The 145 system, which is undergoing a massive change this month as we are talking, is again, a huge addition, add-on to the clinical training matrix or e-portfolio for the residents. And they are very much keen on, if they are learning something on site and the trainer is discussing with them or the teams are discussing with them, that they put everything on the e-portfolio, and then they have a one-on-one resident trainee-led communication and talk about their training exercise, whichever exercise that may be, a pre-op or a post-op or a clinic exercise or a ward-based exercise. Now, so again, it was very important to build relationship with our colleagues on board. As I said, we have a huge group of training program directors all over in Riyadh, from Jeddah, from all over Saudi Arabia. We meet often, and also we are in touch on a WhatsApp group which has daily updates of whatever is coming from. And again, we collaborate in such a way that we have, initially when we did not have a simulation training lab, we were sending our residents to local hospitals like King Faisal and King Fahad. And now we have, alhamdulillah, our own simulation training lab, which is working efficiently for all the simulation scenarios, including laparoscopic training, including surgical training, including obstetric scenarios and ICU scenarios and ER scenarios, etc. So what we decided was that we are going to be impactful. And how impactful that became was that the residents made our job very easy. Remember that we are the boomers, and we are dealing with Gen Z. So you have to come to the level of Gen Z to be able to have a connection. I hope you all understand what I'm saying. So the most important thing is to get ourselves familiarized with what their training need was, how they want to be trained was the most important aspect of structuring out our format of training in Dr. Suleiman Al-Habib. So we do a communication skills workshop very regularly. We do case-based discussions very regularly. We do simulation training, and there is a lot going on in terms of different departmental-based workshops as well. So I'm from OB-GYN, so I can talk to you about CTG workshops. I can talk to you about situational awareness and clinical practice skills in the labor ward. I can also talk about surgical skills training. I can also talk about legalities and legal pitfalls in obstetric training that we have developed, and it's running very successfully. We do it on an annual basis, and we do talk to our residents about, because as you know, that OB-GYN and then anesthesia are the highly litigious fields all around the world. So in terms of safety and quality, what we emphasize on is that, say for instance, if our residents are training in a high dependency unit, they are aware from day one on what is an incident reporting, what is a near miss, what is a serious untoward incident, how to report them, how to be non-judgmental, how to come back and reflect on your own work, how to discuss that with your peers. So there is so much that needs to be translated on a humanoid basis because everybody over here may be a healthcare personnel, everybody may be a nurse, everybody may be a doctor. But in order to become a safe healthcare practitioner, it's very important that these characteristics and these properties are translated into our young residents from year one, and that's what we are striving to do. And then, so the training engagement is again very, very necessary, and I will give you a small example that, every morning meeting that we do, the morning meeting ends with doing single best answers and also with at least 2 OSCEs. So not only our trainees are doing morning meetings, but they are also doing exam practice. So this is a very scientific way of teaching, that whatever they have learned in the meeting, they will do SBAs and they will do OSCEs. So alhamdulillah, our R5s who have recently passed out have already taken and passed their Part 2 Saudi board exam with 100% success rate. So this was our key of amalgamating clinical practice with exam practice on a daily basis. Okay, and how do we measure our training outcomes? So we worked very hard with our teams on ground to make key performance indicators for our academic department. So our key performance indicators are our exam results. Our key performance indicators are our trainee results. Our key performance indicators are our research results. So it is mandatory for all the trainees who join us every October to be assigned to a research mentor and finish their research within the next 2 to 3 years and present that research. And we also have our own journal, inter-hospital journal, and we are linked with external journals so we can help our trainees to become writers of research articles in international journals, and of that there are many examples being published. Okay, so bridging between the cultures is very important, so we had to go to ground level to understand, and I can tell you some very fine stories. In year one, when the residents come, they may have some issues that they find or feel very difficult and challenging, and at some point in time somebody would come to us and say they are coping very hard but they are not able to make it, and they might want to think about changing their field, or they live very far from this city and they want to go back to that city. So these are the issues that we discussed with them, and we went to as far as solving those issues for them. If there was an accommodation issue or if there was a parental issue. We also had one very interesting example where a dad called us and he said, I have 7 daughters and this is my eldest daughter, and I think I have made a mistake. I don't want to send her to Riyadh, I want her back in Jeddah. So we sat with the family, and then we worked it out, and she passed out from Habib last month. So she completed her training program. So that was a success on her part as well, and I will let you hear what that resident's mother said in the end. We have a small video to share with you as well. Okay, so this is our recent passed out residents. And in the center, you can see best poster presentation in our recent international conference that Dr. Kawakib one, and they're all very proud to present their work, their scientific work, their research work, and the overall feedback that we get from our residents from all disciplines in Sulaiman Al Habib is a positive one, that, you know, their expectations were different when they joined, but since they have joined and since they are completing their training, their expectations have changed to the more positive, and they will encourage other residents to join us and apply for Habib as well. All right, so this is also another success story. Two of our residents who passed out then became fellow. One has finished her fellowship from Toronto, and the other one from North America, and they are coming back and joining Habib as a consultant. And the future is here. We have 7 new residents joining us in OB-GYN and 80 plus residents all over from the first week of October. And we had the privilege, we had an academic excellence reward. So from the last 3 years, yours truly has been having the Best Director Award and the Best Training Program Award from Sulaiman Al Habib Medical Group as well. And then these are some of our activities. And this is a huge research award that we do every year, in February of every year. And this is a presenting research award not only to Habib researchers, but from researchers all over the world. So last year, a very fine gentleman from Bangladesh won the top prize for his research work into microbiomes, and we flew him all over from Bangladesh to give him his award. All right, so if you can please, audiovisual, can you please run this video for me? Can we run this video, please, if possible?
كان لها دور بإعطاء فرصة للبنات للدراسة، وهذه صراحة تحسب لها أولاً عند الله سبحانه وتعالى، ثانياً عند الناس، عند الموجودين. صراحة يعجز الواحد إنه يتكلم في اللحظة هذه. إحنا فخورين جداً، فخورين بمكانتهم، فخورين بالأساتذة اللي معهم، وإن شاء الله نشوفهم في أعلى المراتب. كل الشكر والتقدير يا دكتور، كل الشكر والتقدير للدكاترة جميعاً.
Okay, thank you very much.
Okay, so ladies and gentlemen, today is a day of recognition in which we are rewarding the most esteemed health practitioner, and presenting this award on behalf of the Saudi Commission for Health Specialties is the Deputy Secretary General for Health Educational Affairs, Dr. Lubna Al-Jaffali, coming to the stage. Ladies and gentlemen, round for applause for the most esteemed healthcare practitioner, Dr. Sulaiman bin Ali Al-Mahayya. Thank you all for listening. This concludes maybe the first half of our day. So we will be going to a 10 minutes break. After 10 minutes, we will come back with our speakers and with our sessions for the day. Thank you so much. يعطيكم العافية جميعا. We will continue إن شاء الله الحين. So we will start going back from the break with an interesting session named From Lab Coats to Helmets, in which transforming hobbies into health awareness practices. Dr. Basim Al-Bhairani from Johns Hopkins will share an inspiring story how healthcare professionals transfer their hobbies into health awareness initiatives. So welcome to the stage, Dr. Basim Al-Bhairani.
All right, Assalamu alaikum. Good afternoon. So the presentation today is going to be from lab coats to helmets. And it gives me a great pleasure to be part of this great event. And I truly thank all the organizers for reaching out to me and asking me to be part of this event, to share my story with you, which could be everyone's else's story. Every one of us has a passion. Every one of us has a hobby. And the story I'm going to share with you is my story, but it could be everyone else. So from lab coats to helmets, passionate practitioners transformed their hobbies into a dynamic health and medical awareness movement. Quite a mouthful, but I'm just going to share the story with you. So in today's world, basically we have a fast-paced world. It's where healthcare professionals are finding creative ways to merge their expertise and their personal hobbies, where they can promote the healthcare they practice and reach out more audience by practicing it. And by doing so, you're engaging the community and through hands-on activities, and this will reach out more audience and in an accessible way. And it's all about prevention, but it's also about education and building a long health habits in the community. So when I was approached by the organizing team and was asked to talk about my experience in being an emergency physician and a biker at the same time, and how I integrated my hobbies into my, I have two passions. I'm a really passionate emergency physician. I really take care of my patients, but at the same time, I'm a passionate, hardcore biker that I've been biking since 2000, and since we are in the era of artificial intelligence, I asked artificial intelligence, by giving them the topic, to come up with a picture, and that's what AI came up with, and I kind of like it. It integrates the me being a biker, but at the same time being a physician. So why does it matter? So basically, as healthcare workers, we see patients in the traditional setting, right? We see them in the clinic. If you are working in the inpatient setting, you will see them in the inpatient setting. I see them in the emergency department in my setting. These are the traditional setting that we see patients in. Now, but we could actually, we could reach audiences throughout our hobbies. We could reach them, we could reach larger audiences, and we can promote and foster great trust between the doctors and the patients, because they will see you not only as a physician, but also as a human being with their hobbies. And this will impact, obviously, their mental and physical health, as well as encourage the active and healthy lifestyle when promoting such activity. So I'm going to tell you just a brief story about my background. So I went to medical school in King Faisal University in the Eastern Province. It used to be called King Faisal University, but then it was changed to Dammam University, and then more recently it was changed to Imam Abdurrahman bin Faisal University, and that's how we know our university today. And then right after graduation, I joined the military hospital here in Riyadh, the RKH hospital, for 2 years. I did internal medicine residency training for the first 2 years. And after that, I got an offer from Aramco, the hospital, and I joined Aramco Physician Development Program, which prepare you to, for training outside the kingdom. So, and I was then sent to Ottawa University in Canada, where I did my emergency medicine training. And it's a 5-year training program. And in the 4th year, which is an elective year, I did pediatric emergency medicine. And after I came back, currently I'm working with Aramco Hospital, which became a joint venture with Johns Hopkins Medicine and became known as Johns Hopkins Aramco Healthcare. So altogether, I've been working for this hospital for close to 25 years. And throughout my journey, I basically found that I'm really interested in education, really interested in teaching. So right from the beginning, I started taking courses and started learning and taking all the required courses to become a teacher in these courses. So currently, I'm an active instructor of all these courses. I teach advanced cardiac life support, pediatric advanced life support. I teach ATLS, I teach PHTLS, basic disaster life support, advanced disaster life support, fundamental critical care support, fundamental critical care support of OB. I only do the emergency part of that, not the OB part. And as well as I do pediatric fundamental critical care support. So obviously I'm really passionate about teaching. So this is my, what I do, and in addition to being an emergency physician and taking care of my patient during my clinical shifts. But I'm also a biker. And as I said, I'm a hardcore biker. Like, I traveled around the world on my bike. This is me on my bike. This picture was taken in the southern part of Saudi Arabia. It's in Asir area, and the ride that I took part in was called the Sarawat ride, and so where we tour the southern part of Saudi Arabia. Really a great place to visit. We started our tour in Taif and then went to Al-Baha, Namas, Balahmar, Balasmar. We ended in Abha, Rijal Alma, and then we went back to Taif. It was really a great tour. And so this is my other passion, as well as being an emergency physician. And I belong to a team, and that team is called Fursan al-Khalij, the Gulf Knights. And we are a group who are, I wouldn't say passionate, we are obsessed about safety. And if you see us ride in the streets, This is an iconic picture of us that you will find if you go to the motorbike shows everywhere, where they use it as an exemplary for riding, safely in the streets. Unfortunately, what happened is a friend of mine who is also a biker lost his life. And it wasn't an accident or anything, but it's just that he felt tired, he stopped his bike, and he collapsed. And at that time, a video of people attempting to help him went viral. And I wasn't really happy about the way he was, people were trying to help. Obviously, it was out of good intention. But that instigated me to start, at least within the bikers community, of how to do resuscitation, how to do basic first aid, support. I started communicating with some of the, obviously with my team first, and then we communicated with other teams in the Eastern Province. And we started running these sessions where I give, basic life support, basic first aid, courses to the biker communities. And we started with this session, which was held in Bahrain Harley owner group. And then it became a very popular session where we were asked by other teams, other biker teams, to give this session to them, and it became a really good opportunity for me and other members in my team to approach other teams. It was good time, but as well as teaching, and spreading the knowledge about how to do basic life support, how to do first aid if somebody is injured, whether they are on the bike or off the roads. And I truly have to give thanks to the Harley owner group, the Bahrain chapter, and the Share the Road group, شاركونا الطريق, because they supported me in giving these sessions, and they were great help at the beginning. And I guess news spread around and of these life support courses and all these sessions. So I started getting requests from schools and from institutes if I could give their kids, these sessions, and it turned out to be, really fun. I really like working with kids, giving them, basic instructions, basic medical knowledge. They asked the best questions. I really enjoyed, I'm still enjoying, giving these sessions around. Now, working for Johns Hopkins Aramco Healthcare, obviously I sometimes get asked by Aramco to give these sessions to Aramco employee, and promoting, safety, promoting basic life support and first aid from between time to time, and quite an enjoyable sessions as well, spreading the knowledge among these employees. Obviously, I cannot cover 60,000 Aramco employee, but I do my best from time to time, doing these sessions along with my healthcare workers in the emergency department. Now, this is also one of the participations that our team did as part of participating in promoting breast cancer awareness in the Eastern Province, the Sharqiya Wardiya. The Eastern Province is pink, and we used our hobby. We enjoy our ride to the event, and at the same time, promote awareness about breast cancer in the Eastern Province. And this became an occasion that is almost done annually in the Eastern Province. This is also another event which is basically about promoting cancer in awareness in general. And again, our team is always invited to promote healthcare and to promote awareness about these events. And again, this became an annual occurrence. Now, in the Eastern Province, if you know that we have the highest prevalence of genetic blood disorders, namely sickle cell disease, thalassemia, G6PD, and I personally have family members and lost family members because of these diseases. So I feel the pain, I feel what it means to have these diseases in the family. So our team, and we became an active participant in these sessions that promote awareness about these genetic disorders, as well as basically donating blood. We participate habitually in the blood donations campaigns that happen in the Eastern Province, and we are really happy to be always part of that. Now, at the University Hospital, an orthopedic physician, her name is Dr. Dalal Bubshait. She noticed that there is an increased trend of injuries, especially during weekends, especially during holidays, especially of the kids riding motorbikes, especially the off-road motorbikes, the off-road quads and ATV. So she came up with an initiative to Imam Abdurrahman bin Faisal University Community Service Department. And actually, they kind of liked the idea, so they've reached out also to me as a physician and as a part of the biker community. And it turned out to be really one of the largest and great initiative in the Eastern Province. Is called Tarfih Amin, or safe riding or safe entertainment, where we actually the amount of governmental and non-governmental sectors that participated in this initiative was amazing. We set the rules for kids and utilizing the quad bikes, off-roading in a safe manner. We reach out to the people providing these services. We gave them sessions in basic life support and in first aid support as needed. Told them about the safety gears that has to be done and has to be available for these kids. And it turned out to be a great success that I'm truly, truly proud to be part of this initiative that took place in the Eastern Province. So these are part of, putting the metrics and the safety gears and the safety requirements in these quad bikes for kids to use it, setting the age limits for these kids to use them, but as well as we worked on the safety practices of bikers in general in the roads, promoting safety and promoting, sharing the road in a safe manner. So, overcoming barriers, obviously, with the time constraint. I'm a physician, I have a full-time job, but at the same time, you can balance your professional requirements or professional life and, fulfilling your personal interests, your personal hobby, and utilizing this passion to feed the other passion. And at the end, what I aim is always to deliver the best community service, promoting health, promoting safety among my community. This is the second attempt of me asking artificial intelligence to come up with a picture, for my presentation, and it kind of, I kind of like this picture because I'm a physician, but a kind of superhero that comes out of it to be the biker who goes out there to help the people. But it's amazing what artificial intelligence can do to help your presentations nowadays. And so the future of the message that I want to end this presentation with is that the future of health advocacy is not only about seeing patients in your office, on your clinic, in the emergency department, but actually reaching out to them. Use whatever hobbies, whatever interests that could get you to mix with these people as a human being, as a friend, as a biker in my case, and spread the safety and the message that you want to advocate for. This is a picture of my team for San al-Khalij. We always, gather annually, and and I truly thank them for supporting me all the time, attending these events. And my last slide is that this is a birthday card that was sent to me by one of my dear friends a few years ago. I would say many years ago. Okay, so and it sums up this presentation. The person, the son, the brother, the husband, the father, and at the same time, I'm the emergency physician who takes care of his patient with the best care possible, not the standard of care. I always say, aim for the excellence of care. And at the same time, I'm the biker who utilizes my hobby to promote healthcare to my community. And with that, I thank you very much for listening. So they're telling me that we have a few minutes for questioning. If you have any questions, I'll be more than happy to answer them. So if we have no questions, thank you very much. And thank you very much for the organizing team for inviting me to give this speech about my humble experience. And I'm really thankful to be part of this great event. Wish you all the best.
Thank you so much. And we thank our last speaker, Dr. Al-Bahrani. His presentation reminds us of the power of passion and creativity in healthcare awareness. Ladies and gentlemen, today we are also rewarding the largest training center in terms of the number of active trainees, and presenting this award is the Secretary General of the Saudi Commission for Health Specialties, Professor Aus bin Ibrahim al-Shamsan. And receiving the award is Dr. Fahad Al-Ghfaili, the CEO of Riyadh Second Health Cluster. Ladies and gentlemen, thank you so much for tuning in. We will be going on our break, that it will take 10 minutes, and we will come back afterwards. Thank you so much. Okay, ladies and gentlemen, we're back with an exciting session named Leading the Way. It's a story about accrediting the virtual health hospital. Dr. Ibrahim Belharith is the Executive Director of Governance, Quality and Institutional Excellence at Sahha Virtual Hospital. Will discuss the pioneering work in virtual healthcare accreditation. So welcome to the stage, Mr. Ibrahim.
السلام عليكم ورحمة الله وبركاته. First of all, I am honored to stand before you today to discuss our journey in Sahha Virtual Hospital to take the first certificates as a virtual healthcare in education. Our achievement today, and we are proud of it, to announce that Sahha Virtual Hospital has been officially accredited as one of the training center by the Saudi Commission for Health Specialties. I will take you around first about the virtual hospital and telemedicine. So you know that the rapid advancement of digital technology has completely transformed the traditional health care to the new way of providing care, which is virtual health care and telemedicine. The key technology driven the change, including the electronic health records, which allow for better access to patients' information, and also the mobile health apps. As you know, that Sahhati now it is used by a majority of Saudi people. Let the patient track their health and communicate directly with the provider from anywhere and anytime. Additionally, the wearable devices, now we use it in Sahha Virtual Hospital and some of the virtual clinic, which give the patients the access to follow with the providers about their health. Also, the AI-driven, and this one of the biggest transformation of health that use AI-driven diagnostic, which is used now as an imaging technology. Going back to the telemedicine and the history, some of the studies that said the telemedicine has been around since the 1960s, which when the healthcare provider first start using the telecommunication to reach patient in remote area using radio and TV. In recent years, it used to be growing rapidly, as between 2018 and 2020, the number of healthcare providers using telemedicine nearly doubled with the COVID-19, and the pandemic played the huge role in this shift. For example, one virtual healthcare provider saw now, when they start in 2020, they saw only 1,600 patients, but in February 2022, they reached 90,000, around 90,000 patients only from after only 2 months from that same year. This shift has helped focus more on patient-centered care, and which improve the healthcare accessibility and also the patient satisfaction. So what is virtual healthcare? Virtual healthcare refers to the delivery of healthcare services and medical care through the digital platform and technology without the need of the patient to be visit in any in-person clinic. That's mean providing the healthcare using digital tools so patients can get any care without needing to visit any physicians or nurses in person. And what is the global impact of virtual healthcare That's increase the engagement of the patient and satisfaction, address geographical barriers and also the time and cost efficacy, and also the improve the coordinations, and this is what we will talk about it after, and easier knowledge transfer between medical professionals, and this is what we achieved through this accreditation. So in the literature review, as you can see in the screen, they said that 90 or 50% of the healthcare leaders saw or predict that by 2040, you will at least see the quarter of all outpatient care and preventive care, long-term care, and well-being will be virtual or will be transferred to provide by virtual care. 75% of healthcare leaders, they expect significant increase in the industry-wide investment of virtual healthcare. As you can also see in the screen, in the pictures, the care coordinators, that about 1 in 2 physicians see improved care coordination of quality of care through virtual than physical or in-person clinic. 74% adherence rate on average for heart failure medication through home-based telemedicine or hospital at home. And also enhance the consumer experience or patient experience. As you can see, 2 in 3 health plans think virtual healthcare has improved overall the member satisfaction, and this is what we achieved in Sahha Virtual Hospital. And this year we reached 87% of patient experience. They are satisfied with the service that is provided. Also around 97% of satisfaction from 937, which is telemedicine platform. Improve efficacy, and you can see that patients save about 2 hours, that's on average per virtual visit compared to the physical visit. Expand consumer and clinic access. More than 50% of the health plans numbers encounter are virtual. Zooming to Saudi Arabia, and you can, as you know, that's one of the biggest change in Saudi Arabia, which is the model of care and the transformation of healthcare. The Kingdom of Saudi Arabia has already taken many steps to optimize the healthcare offering, starting with the Vision 2030. And as I said, the major component of this is the new model of care, which focus to modernize and improve how healthcare is delivered across the country. And one of the key area, in the, as you can see in the picture, which is the rapid adoptions of healthcare, virtual healthcare. This is the digital health implementation in Saudi Arabia. As you can see in the screen, Saudi Arabia had a lot of initiatives for e-health and digital health, starting from 2017, when the Ministry of Health launched the 937 Service Center, then Maw'id apps, and then Wasfati and Sahha and Sahhati. Now we have Sahhati and Sahha. A lot of these applications is still continuous to provide e-health and telehealth care through these apps or the platform. So what's Sahha Virtual Hospital? Sahha Virtual Hospital is a specialized hospital that considered as a pioneer in the providing specialized care to patients remotely without attending them to any hospital. Sahha Virtual Hospital, we have a building in the digital city in the MOH. Our experts, they are providing their care through that hospital to all the regions in Saudi Arabia through the applications or through the platform or virtual platform. Sahha Virtual Hospital also, it's recognized as the largest hospital globally, and also as you heard yesterday, our Minister of Health, when he announced that Sahha Virtual Hospital also obtained the Guinness records as the largest remote hospital internationally. Saha Virtual Hospital starting provide service in 2022, but we launched the hospital officially in 2022. First virtual hospital accredited globally as a diamond level of Canadian accreditation, and also it is the biggest of its kind in the world, as I said to you, first in the Middle East, and one of the training center in Saudi Arabia accredited by the Saudi Commission for Healthcare Specialties, and we obtained also 4 certificates in ISO, and also we are certified from the Saudi Commission of Health Specialties to provide continuing professional development activities and program. The main pathway for providing service in Saha Virtual Hospital, we categorize it to 6 categories, which is the virtual critical care, virtual medical support services, and virtual scheduled specialized care, and physical home care services. Then the virtual multidisciplinary team and virtual medical consultation, which is immediate and clinic through the 937 or through Sahati application. So the critical care virtual consultation, our healthcare professionals, they take round for all the patients in the ICU with the partner hospital we are connected with, providing all the services starting from the assessment to the diagnosis, planning, and then the implementation of care plan with the partner hospital that we are connected with. Also, we have the virtual stroke department, which is give immediate critical care to around 47 partner hospital we are connected with for our round of for all the regions in Saudi Arabia, providing them the all necessary care plan that they need for the patient. For the virtual specialized clinic, which is specialized clinic sub specialties that we provided to the all region in Saudi Arabia that they don't have access to the consultant in this specialty, we provide these services remotely through the platform that we have. Our experts, they are dealing with the partner hospital healthcare provider, giving them the all care that the patient needs, discussing with them through the shared clinic what the patient needs for their care. Multidisciplinary virtual committee, and we have around 4 virtual committee now. We have the cardiac committee, we have the diabetes committee, we have also the psychology team, and also the virtual tumor board. These we have from different specialty. They are grouping together and discuss case by case if there is any cases or complex cases that they need any second opinion to give it to the partner hospital they are connected with. Virtual medical support services, which is the virtual radiology and EEG and pathology. Our experts, they are support their medical decision by continuous and gratuity provide optimal medical care. Home care services, and this include rapid or remote monitoring of heart failure patients, and also IRADA home care services. And now we launched the wearable devices, or what we can call it, we call it by Arabic al-Murshid al-Iftiradi, which give the coaching to the patient that they have wearable devices in their home. So the patient, they have wearable devices. It's like a kit. If you have time, you can visit us in our booth to see this kit. This kit, it is connected with us by platform. Our AI, they will prioritize the patient that they need care through these wearable devices, and also connected them with our provider, which is the physicians and nurses, and then they will provide the care immediately to these patients. We have medical consultation, and I think the majority of our people in Saudi Arabia, they use it, which is 937 medical services, and also through تطبيق صحتي application, which is immediate. If you want to immediate consultation, you can use it now, or if you want to book a clinic through this application. Now we reach around more than 14 million. They are user for this services. Inpatient counseling services, and this is one of the services that we launched this year by providing remote inpatient to those hospitals, especially small hospital, 50 beds, that they don't have consultant in some specialty, so we provide the service through these services. Second opinion service, and this is if any patients or any healthcare providers in Saudi Arabia need to have second opinion, we are provided remotely directly to the patients or to the hospital. The golden number we reach now, we have around 30 main specialties in our hospital, 81 subspecialty offered, and also we reach around more than 200 partner hospitals. They are connected with us. Our subspecialties that we provide, the beneficiaries that they use these services, around 200,000. But for the, as I said, the community, we reach more than 14 million patients. So I will take you just a small journey in our accreditation by the Saudi Commissions for this training. The importance, as you know, the importance of the accreditation, especially in the virtual health. Virtual health, it is a new trend. Saudi Arabia, they are the leading globally and the leading the world in the virtual health. So we try to mix our services for research and also for training and also to provide the services. So one of the main categories that we work on it is to get the accreditation from the Saudi Commissions to make sure that our providers, they participate also to provide any training for the healthcare provider that we are connected with. So, of course, to ensuring quality standards, and this is what we are looking on. So we provide, as I said, in our goal in Saha Virtual Hospital, we provide knowledge to the healthcare providers that we are connected with, but we want to make sure that how this training is efficient. So we have to ensure the quality standards in this accreditation. Enhance patient safety. Safety, always. It is the first priority for us as a quality and also for us as a healthcare provider. Global recognition and trust, and also improve provider competencies, and this is, we talk about the virtual health competency. Facilitates the technology's advancement. This is what I discussed in the beginning, and promote continuous improvement for our healthcare providers, and also align with the national health strategy, which we want to achieve by 2030. So STEP Saha Virtual Hospital took to achieve this accreditation. First, we start by initial assessment and planning. We received the standard from Saudi Commissions, and then we have to understand what is the requirement, and then what is the gap analysis, especially for virtual hospital that they don't receive patients. And a majority of our experts, they are more than experts, they are consultants in their field, especially the physicians and nurses and allied health provider. We try here to measure or analyze the gap. Then we make the strategic planning using our resources, making the team be ready to utilize this requirement. Then we build our capacity and infrastructure. Saha Virtual Hospital, alhamdulillah, they are supporting from the leadership to have any infrastructures and capacity. So we're choosing the training program that it is applicable now for us. Then the faculty development, and try to find the trainers and the instructors that they have to provide this training. How we integrate the technology and the platforms that we use, and make sure that the healthcare providers in any region that they will use this technology to provide the training to their trainees. Quality management and continuous improvement, and this is one of the biggest steps that we took, especially with the establishing of the quality management system and internal audit and evaluation, and do some mock survey, and then we get the feedback and improvement cycle. Then we try to document and submit all the papers that we have or the documentation to prepare for the Saudi Commission's visit. We received the visit 2 months ago. The external review by the Saudi Commissions, they give us some comments, and then it was on-site assessment, and we have also one virtual assessment. We got the feedback and the final adjustment, and then we achieve, alhamdulillah, the accreditation, and we celebrate yesterday and to take recognition, and then the feedback and improvement cycle. We still continuous the post-accreditation continuous improvement. As I said, accreditation, it is not just the last step or the final step. We have to continuous and ongoing monitoring and compliance. This is the training program that Saha Virtual Hospital accredited for now, diagnostic radiology and family medicine. So our healthcare providers or trainees in any region, they can get their training, but they have to register in Saha Virtual Hospital. Then we can monitor them through this technology platform to take these courses with the Saudi Commissions. What is the future plans for Saha Virtual Hospital? We are working now with the Saudi Commissions to have our own virtual programs, especially for physicians and for nurses. And this is what we aim to do, to integrate the technology and virtual healthcare inside the education and training, especially the structure education. So this is the last, I think, topic that I have. Saha Virtual Hospital, a regional leader now. As I said, we are in Saudi Arabia leading the virtual healthcare globally. And Saha Virtual Hospital received this recognition from the Saudi Commissions to make sure that Saha Virtual Hospital be the leader in virtual health education and competency. So we are validating the high standard and excellence in our work to have the quality benchmark and commitment to innovation. And then we have to enhance the regional and global recognition by announcement of this education. And then we have to build skilled virtual healthcare workforce. And this is what one of the main goals that we needed from this accreditation. Lastly, we have to support the national healthcare goals. And as I said, in Vision 2030, that we want to achieve that all the healthcare providers, they provide virtual care, they have to be competent in some of the skills and knowledge and attitude that it is necessary for them to provide, and to make sure that they provide the quality of care to our patients, and also to attract top talents and partnerships, especially with the clusters and some of the organization, governmental or private, that we are looking with them now to lead the virtual healthcare. Also, we have to expand the training program and innovation, and this is what I said, that we are planning in 2025 to have our own virtual healthcare education program. Finally, sustainability, this is one of the main goals that we have to work on, and lifelong learning and professional development for this healthcare provider, and also contribute of healthcare transformation. In conclusion, of course, achieving the Saudi Commission for Health Specialties accreditation has established Saha Virtual Hospital as a pioneer leader in virtual health training, reinforcing them as a commitment to excellence and innovation and the development of highly skilled healthcare workforce in the region. Thank you so much. Allah Hafiz.
So we share a thankful message to Mr. Ibrahim for this groundbreaking development in virtual healthcare. Moving to the next session, we will speak about emotional safety and when emotion can be taught. And presenting this session we welcome to the stage Ms. Clara Smith, and she will be taking us through the journey of the emotional safety.
What if I told you that 80% of children diagnosed with a life-threatening illness leave our hospitals with a new symptom that they didn't have before they entered our walls? I'd like to tell you a story. This is a story of Nora, a 7-year-old girl who's admitted to the hospital for the first time. Her parents tell her that the people in the white coats and the funny masks are there to support her, but all the new sights, the new sounds, the new smells, the new words prime Nora's brain to be ready to fight or flight. She's constantly scanning for threat. Nora is admitted to the inpatient unit, where she's soon taken to the treatment room and told that she will need an IV. She's asked to lay flat on her back on a bed while healthcare members hold her down. While her mother came into the room with her, there's so many healthcare members in the room that they eventually get separated. Nora struggles trying to get up to find her mom, but the more that she struggles, the more she's held down. All of a sudden, the staff starts talking at the same time. You're okay, hold still, this'll be fast, take a deep breath. But the more that people talk, the more scared Nora gets. The more scared she gets, the more she struggles to get away. And the more she struggles to get away, the firmer she's held down. Soon, Nora will feel the pain of the IV, followed by tears, and eventually she'll be reunited with her mother. But as they return to the room, the staff notice that every time they enter, Nora hides underneath her covers or yells for the staff to get out. Now, you may understand that Nora will then move to go on to different procedures and different tests throughout her medical stay. Sometimes she'll be awake, sometimes she'll be asleep, sometimes it will hurt, sometimes it won't. But the unknown is what becomes scary to Nora. Eventually, Nora will move to a new unit. On this unit, it's a little bit different. She notices that a lot of the kids don't have hair, and the adults seem to speak in hushed whispers. Her parents have concerned looks on her face, but they tell her, everything's okay, there's nothing to worry about. But it's really hard for Nora not to worry when no one's telling her what's happening, and she doesn't know who she can go to for her questions. Eventually, Nora will leave our hospital. She will have a new diagnosis and a new treatment plan. The medical team will have done their job. But Nora will also leave with new nightmares, increased separation anxiety, and a fear from the hospital and doctors that will follow her through adulthood. Now, you may understand that Nora is a fictitious representation of a number of children I've worked with throughout my career that I'm using to make a point today. But lest I lose credibility, I'd like to share a couple stories of some patients that I've worked with throughout the world. Abdullah was a 10-year-old boy who was having 2 chest tubes removed without any form of sedation or pain management. He had autism, which caused him to have sensory processing disorder, so he got very upset anytime staff came close to him. When it came time to remove his chest tubes, Abdullah started to kick and hit and scream and spit. He was terrified. In fact, he screamed so loud that the medical staff did decide to take him to interventional radiology, not to provide pain medication, but so that his mother wouldn't have to hear his screams. He looked at us with terror in his eyes as that procedure took place. And it took over 15 minutes after it was over for his body to stop shaking. Nazreen was a little girl who was 8 years old who was admitted to the hospital for meningitis. Upon admission, she was taken to the OR where, without any sort of preparation or education, she received a double leg amputation. She woke up from surgery to find out that she didn't have any legs. Understandably, this sent Nora into a deep depression, and she had a panic attack every time she was told she needed to return to the OR, even though the staff told her that they were just doing wound debridement, because she was terrified of which body part would be missing when she woke up next. And finally, little Cara Lou, who was 2 years old and ran away from her mother at a museum, resulting in a fall that ended up with her going to the emergency room for stitches. She was taken out of her mother's arms and placed on a papoose board where she was strapped down and made unable to move. She cried so hard and so loud that the medical resident declared he would never go into pediatrics, and Kara went on to lose her voice. But she found it and grew up to become a certified child life specialist who stands before you today to share on behalf of the patients and families we serve about the emotional safety of children and families. All the children that I just spoke about left our hospital physically healed. We as a medical team had done our job, but 80% of them leave with a new diagnosis that they didn't have before they came to our hospital. Pediatric medical traumatic stress. Whoops, wrong way. There's my mom. A set of psychological and physiological responses of children and their families to pain, injury, serious illness, medical procedures, and invasive or frightening medical experiences. Symptoms such as invasive thought, avoidance, and hypervigilance. It's simply not acceptable for patients to be harmed by the same healthcare system that's supposed to offer healing and comfort. So I'd like us to pause for just a moment, because I want to ask you, what did it feel like in your body as I shared those stories? Because studies show us, well, before I say that, because as I was preparing for this talk, I had some friends look over it and they said, you really shouldn't start a talk with so many challenging experiences. And I said, I'm talking to a room of healthcare workers. I've just described to you what they witnessed before their lunch break. But seriously, studies show us that healthcare workers are at increased risk for secondary trauma, for compassion fatigue, and for burnout, largely based on witnessing and providing preventable harm to patients. So while I'm here to advocate for patients and families, I also want you to know that I see you. I see the work that you do every day. I see the challenge that is to you. And so for me, this message for emotional safety is just as much for you, the healthcare worker, as it is for the patients and the families that we serve. So let's take a breath. In the hospital, we ask children to pick a flower and get some bubbles. So everybody get your flower and your bubbles. And we smell our flower, and we blow our bubbles. Smell the flower, blow the bubbles. Because what I would like to share today is a message of hope. A message where Nazreen has leukemia explained, or Nora has leukemia explained to her in a way that a 7-year-old can understand. Where Abdullah's medical team collaborates to come up with a plan that leaves him empowered, not terrified. And where Nazreen is prepared for her surgery in a way that leaves her feeling safe, secure, and supported by a medical team that she knows that she can trust. This story is the story of emotional safety. Emotional safety is the intentional, interdisciplinary practice to promote resilience, healing, and trust for pediatric patients and their families during medical procedures. It's a solution-focused approach to meeting the unique individual, psychological, emotional, and developmental needs of children and their families. Emotional safety is our reminder of our duty to first do no harm, and beyond that, to intentionally do good. Emotional safety is built on 4 pillars. The first pillar is screening and assessment, where those children and families most at risk for emotional distress are identified early and intervention provided through systematic multidisciplinary communication. Interventions such as individualized intervention, where we recognize the unique developmental and psychological needs of children and families. Interventions such as communicating in emotionally safe and developmentally appropriate ways, telling children the truth about their bodies, about their diagnosis, and about their treatment, because truth builds trust. Interventions where children have things explained to them in a way they understand. For example, they might be prepared for an MRI or a CT using toys, videos, and sounds. allowing them to not need sedation for that procedure, which we know is proven possible by preparation's ability to increase cooperation, decrease anxiety, and increase patient and family satisfaction. Interventions such as providing comfort measures during painful or stressful procedures, such as comfort positioning, in which a parent is allowed to hold their child in a safe and secure hold, analgesia or topical anesthetics to decrease that child's perception of pain, clustering lab orders so we reduce the number of pokes a child needs, and providing distraction and support during stressful procedures, which allow a child to build skills for resiliency through taking deep breath or maybe focusing on something other than the pain. And another pillar is that of environment, in which we create environments that feel safe and healing to patients and families and help them to find their way in a new and challenging environment. Environments in which the culture of emotional safety and of patient needs is integrated into policy, into practice, and into procedure. And finally, screening or education and training, where professionals within our hospital at every level are trained to know and understand their role and their responsibility in promoting the emotional safety of children and families, both at the hospital level, but also throughout the government, as we create opportunities for emotional safety to build competency and build certification within our institutions. It may seem like a lot to hold the emotional safety and the medical safety of patients in our hands, but I want to tell you they are two sides to the same coin. And while it's the responsibility of every healthcare professional to promote emotional safety, there are trained specialists whose primary role is to ensure the emotional safety of patients and families in hospitals. These are called certified child life specialists. Certified child life specialists mitigate the negative effects of stress and trauma before, during, and immediately after an identifiable challenging event. They use an individualized trauma-informed approach to help patients and families build resiliency in some of life's most stressful moments. Certified child life specialists use developmentally appropriate explanations, like teaching a child that an IV is a tiny little straw that goes into the blue lines in your arm or your hand to give your body drinks of water or medicine to help it get better. The child life specialist may even use a blank cloth doll and a real IV to help that child insert the IV and then throw the needle away, so they're left knowing that it's only the little straw that stays in their arm. Interventions such as preparation, where child life specialists prepare children for the 5 senses that they will encounter in a new experience, which decreases the unknown, increases compliance, and decreases anxiety. Interventions such as coping support, where child life specialists use their skills to give kids skills for building resiliency and increasing regulation that they'll be able to use long after they leave the hospital. Skills such as finding a creative way to take a deep breath, providing alternative focus to keep their mind away from what's stressful, or maybe even if a child wants to watch the procedure, narrating that procedure so the child knows what to expect step by step. Expressive arts, because sometimes our biggest feelings, it's really hard to find words for. So we use art to help kids express what those feelings are. We also know that trauma is a multisensory experience, and so therefore healing takes place through multisensory intervention. And finally, play. Play is the language and the lifeline of children. Play is how children communicate with us, their internal world. It renews their natural sense of optimism. It allows them to problem solve and try out solutions to some of life's most challenging problems, and it helps them communicate to us how they're feeling about the world around them. And while child life has been an integral part of the healthcare system in North America, parts of Europe, and a number of countries throughout the world, we're really excited to announce today that child life is making its debut in the Kingdom of Saudi Arabia. But rather than tell you about that, I would like to show you with some of our child life specialists what that work looks like.
حياة الطفل اللي صار عندنا بالمملكة العربية السعودية، والأول مرة. هذه غرفة اللعب المستشفى، وهنا أخصائية حياة الطفل شوق تعلم وتشرح العليا عن الأدوات الطبية وكيف تشتغل، عشان إذا عرفت كيف تشتغل هذه الأشياء بتصير ما تخاف منها. تعالوا هنا شوفوا أخصائية حياة الطفل رغد تساعد سلطان اللي مرة يخاف من الإبرة. علمتها عن الإبرة بطريقة حلوة، استخدمت جهاز الفراشة اللي هو يهز ومعه كمادة باردة عشان تخفف من ألم الإبرة. وصار سلطان يركز على لعبة الفراشة والقصة، وصار ما يتوتر. أحياناً الدكتور يحتاج يصور جزء من جسم الطفل عشان يتأكد من سلامته. أخصائية حياة الطفل امتنان جابت لعبة على شكل جهاز الرنين المغناطيسي عشان الطفل يلعب وفي نفس الوقت يعرف إيش هو الجهاز. وبعدها لعبت ديم مع الأخصائية حركة ستوب عشان تتعلم كيف ما تتحرك وقت تصوير الرنين. أحياناً الطفل يحتاج دواء ينومه لإجراءات محددة زي العمليات، ويكون التنويم عن طريق كمامة خاصة داخلها هواء. أخصائية حياة الطفل ريم تدرب ديم على التنفس العميق، وزينت معها الكمامة بالشكل اللي تحبه، وبعدين علمتها التنفس بطريقة نفخ فقاعات صابون. أخصائي حياة الطفل شخص مرة مميز، يشتغل مع الفريق الطبي وطيب مرة، يخفف عن الألم بطرق حلوة، ويستخدم اللعب عشان يعلمنا عن العلاجات والعمليات وكثير أشياء بطريقة سهلة نفهمها تخلينا نتعود على جو المستشفى.
So let's revisit the story of Nora, but this time through a lens of emotional safety. Nora is a 7-year-old admitted to the hospital for the first time, but this time she's met by a medical team who has both her medical and emotional safety in mind. Nora is taken to a new unit where she's told she'll need an IV, but this time she's met by a child life specialist who explains that procedure in a way that she understands. Nora and her family make a plan for Nora to sit in a comfortable position on her mother's lap during the procedure. She's given a topical anesthetic to reduce the pain, and she chooses to distract with her child life specialist during the procedure. When it comes time for the poke, Nora takes a big deep breath just like she's practiced. Everyone goes quiet as the nurse counts to 3. Nora cries a little bit, but her mother's there close to her to provide the comfort that she needs to calm quickly. Nora will go through a number of other procedures while she's here in our hospital, but each step of the way, the staff have prepared her for what to expect. She even does an MRI without sedation, which saves the hospital money and time, and keeps Nora from taking medicines that her body doesn't need. Nora will be moved to a new unit, but this time she's told that she has a diagnosis called leukemia. Leukemia is when the bone marrow, or the blood factory in her body, that creates all of her blood cells, starts to create unhealthy cells. Those unhealthy leukemia cells make it so her healthy cells can't do their job. That's why Nora is going to need chemotherapy. Chemotherapy will help get rid of the leukemia cells, but it's also going to make her healthy cells weak, which is why she's going to feel sick sometimes, and she might lose her hair. Nora goes on to leave our hospital with a new medical plan and a new treatment, but she also leaves with new knowledge, new skills, and a new trust in her medical team that's going to take her through her medical journey. When we as a healthcare community prioritize emotional safety, we ensure that children such as Nora, Nazreen, and Abdullah feel safe, secure, and supported during their healthcare team. As an interdisciplinary team, we make sure that we promote resilience, healing, and trust in the patients and families that we serve. This is the story of emotional safety. We do better when we know better. So now that we know better, together, let's go do better. Thank you.
Smith, thank you for highlighting this often overlooked aspect of patient care and professional development. So now, moving to our next session, titled Enhancing Global Healthcare Through Health Education. And this session will discuss the critical role of healthcare education in improving global healthcare outcomes. So we have a privilege of hearing from Dr. Lubna Al-Jaffali, the Deputy Secretary General of Educational Affairs at the Saudi Commission for Health Specialties.
Good afternoon, everybody. We witnessed change at the last 100 years ago. We witnessed changes in the incidence and prevalence of diseases such as tuberculosis and leprosy, tuberculosis and leprosy and smallpox, which were prevalent in this era due to poor sanitation, crowded areas, and a lack of access to care. And this was evidenced by, with the advancement of vaccination, these diseases changed and was eliminated. And then with the emotional, the social and the economical changes that we witnessed also, we saw a rapid increase in sedentary lifestyle, unhealthy diet that led to non-communicable diseases such as cardiovascular, cancer, chronic respiratory, and diabetes. And these diseases have been shown to cause death in every 4 deaths, there are 3 caused by non-communicable diseases, and every 2 seconds, someone aged under 70 dies of a non-communicable disease. We also we have been faced with shifts in healthcare delivery. We saw healthcare that is rely on office and solo practice that has been changed to highly functional multidisciplinary teams. We saw decision-making was physician-focused, changed to a more patient-focused approach, entailing the patient preferences and the patient engagement in the decision-making process. We saw patients coming to the clinic with all the information they have. They have the differential diagnosis. They have the alternative therapy. They've done the research and they're asking just for our opinion about the healthcare delivery given. We saw the philosophy of healthcare also changed. For you are my problem when you come to the hospital to you, I will take care of you out of the hospital so you don't come to my clinic and I take care of you. So all of these changes are evident. We saw technology changes. We began with just only x-rays and patient records, which were hard copy, to we reached to medical big data, predictive analysis, 3D designing in prosthetic and implants, and also in designing drug medication. We saw smartphones with us on our hands linked to hospital systems to measure vital signs. All of this was evidence with the fast changes in disease and in also healthcare. There was also changes. There's an educational shift also we saw. We saw in the first, before the 1990, we saw a teacher-centered, relying on traditional classrooms and memorizing, which was focusing mainly, and the assessment was only examination at that era, and focusing only on having the best scientific expert in that time. Then shifted to a more student-centered, focusing on values and social accountability and collaboration. And the main focus was that to have professions in that career. Changing that to a more personalized, learner-driven education, where understanding the gap of each learner and designing the best learner and assessment techniques. All of this was given, and the new term that is used now, precision medication, which is using the learner-driven data to assign the best educational material for that learner. Also, that changed post-pandemic and accelerated with the acceptance on more hybrid virtual room. Before, virtual learning was not really acceptable. Post-pandemic accelerated that, and also the use of AI, augmented reality, and virtual reality, and the assessment became more performance-based and competency-based, and that really was the focus of getting leaders to lead the transformation that the healthcare is going through right now. And all of these characteristics that we are, the changes also, there was changes in generational changes, where we saw baby boomers who now represent around 25% of our population, our workforce, who focus, are very work-centric. They prefer face-to-face and very competitive. And then Generation X, who are work-life balanced, independent, and materialistic, and they have 33% of today's workforce. We have the millennials, who are more toward self-growth and are flexible, and they represent 35% of today's workforce. And now coming the Gen Z, who are more digital native. They know about the digitalization, but they're also aware about their mental health awareness. And they are really, right now, they are 5% of the workforce. So understanding these different generations and different educational changes is a must. And this is one of the a very nice figure that shows how changes in the web during the year affected also changes in health and in education, and in each version of the change in the web, starting from just simply a PC to having a machine learning in Web 4, and how educational health also affected both education and health. All of these changes that happen, and we're still faced, the learner is still faced with certain challenges. We're facing increased patient complexity. We're seeing patients with comorbid diseases like hypertension and diabetes, with social and economical and psychological problems, calling for practitioners with more decision-making and problem-solving and empathy skills to deal with them. We're seeing the learners are faced with high workload in learning, not just the training that they are seeing, the patient they are seeing, but there's also assignments and examination preparing for that, and that's called for having people who can manage their time and more resilient. We're talking about the explosion of clinical knowledge right now that we are seeing, and that the need for evidence-based practitioners who can understand and have problem-solving skills and critical thinking skills to understand what kind of right knowledge they can use to implement in their, and all of this with certain time constraints that they cannot really manage, which is really getting our learners in a more burnout situation, that we're calling for more resilient learners. And this is all also matched with static curriculums that are not matched to the population needs that are we asking for. Population needs, such as right now we're talking about the need of curriculums that meet the global strategies, such as moving towards universal health coverage, protecting people against health emergencies, and ensuring healthy lives and well-being for all. The WHO has released a competency outcome framework and understanding this kind of competency needs that the healthcare professional needs right now. And if you can see, there are 6 competencies mainly focusing on non-technical skills. They're focusing on decision making, communication, collaboration, evidence-informed practice, personal conduct, and people-centeredness. These kind of competencies are the need to answer for to managing non-communicable diseases and other diseases that are now prevalent in this era. And these competencies have to be injected in the learning curriculum from the entry level to the postgrad, and also developing it as a focused competency during their practitioner as a life learner. Designing the curriculums and competency-based curriculums is also faced with having to ensure the quality of these curriculums. Quality of the curriculums is one of the accreditation is one of the important drivers for schools to ensure quality. The problem with accreditation in healthcare, in health education curriculums is that it differs from other kind of curriculums. It should focus on outcomes and educational outcomes, not on processes and learning and the teaching. Just that. Other metrics such as patient outcomes should be taken as metrics for accreditation. Collaboration and partnership is one of the important factors to improve quality through educational institutes, globally and nationally, sharing experiences and building on these kind of experiences and developing them. Also building academic centers, balancing between the clinical services that the academic health centers provide and the research and the clinical services. We're seeing right now academic health centers are focusing on clinical services more than providing the right exposure to trainees. When we go deep in the classroom and understand further what's going on in the classroom, we have, first of all, as I just mentioned, the curriculum. We need curriculum that are relevant, that is patient-focused, focus on patient safety, evidence-based, and competency-based. And when we come to the learner, we also need learners, the appropriate selection of learners, not just focusing on their scores and GPAs, but also focusing on evaluating and accepting candidates based on other non-technical skills, such as resilient, communication, and other kind of skills. And after they come in the learning continuum and start the progression of learning, we need to retain them and follow up their well-being. One of the studies showed in the USA that 1 in 4 trainees has been diagnosed with depression. 1 in 9 of the trainees has been diagnosed with suicidal ideation, and only 16% of these trainees come and ask for help. So designing, monitoring learner wellness to retain them in the system and not losing them is a must. Also with that, designing a mentorship program to follow up with the academic program was one of the drivers for mental well-being also. There is a report published in 2015 showing that more than 50% of the senatorial reports that cause senatorial events are caused by lack of communication between the team, between the physician, nurses, and this is really a preventable approach to do. So having intraprofessional education in the curriculum, early in the curriculum, identifying the role of each, understanding the rules and responsibility of each team member is one of the things that can help us prevent patient safety problems later on. The learning experience have to be, as I said, Generation X are coming, so the learning experience should be more personalized, more adaptive, based on the feedback, and feedback should be an integral rule of education and learning. Also blended and simulation. Assessment should be multifaceted in all in every step of the learning continuum. Assessment should be provided and should be validated. Not just only one assessment should be used, different type of assessment should be used to validate and monitor the educational outcomes of the learners. Using artificial intelligence to our our next generation who are digitally native is also important. We should not be shy with using virtual reality. It's not a luxury right now, it's a must. Augmented reality, and also using gamification in learning and assessment. And mainly one of the most important things is that we are having faculty who are the top niche in their science and experts in their science, but they lack the skills that for teaching and assessing. So there's a need to design and implement continuous developing programs for faculty and teaching staff. So just to pause and understand what should we do really right now to improve our education. We should focus on curriculums that meet population needs. We should prevent any type of patient safety problems later on by introducing interprofessional education. We should retain our healthcare workers by improving the wellness support programs, and we should ensure that the students or the trainees are exposed to the best cases and have the best exposure, and by building alliances between hospitals and universities. And finally, the ultimate goal is having the right healthcare professional with the right competencies, providing services in the right places to better respond to changing population health needs that embraces protecting the safety of our patients. Thank you.
Of health education and advancing healthcare globally. So after the break, which will be 10 minutes break, we will come back with another awards that will be presented by the Secretary General of the Saudi Commission for Health Specialties. So we will only take 10 minutes break and we will be coming. Thank you. Ladies and gentlemen, round of applause to our health professionals who will be rewarded today. سامر طارق أحمد, عبد الإله صالح الموسى, ديما خالد القزلان, يعطيكم العافية ويعطيكم التوفيق. Moving, مزون دغش البلوي. شهد أسامة الكحلة, ريم سليمان الهذلي, هداية عبد الهادي الطريفي, عبد الله محارب المحارب, هبة عبد العزيز الحمدان, أسامة عبد الله القحطاني, وجدان ماجد العلوي, ألف ألف مبروك, بيضت وجيهنا. أنوار خالد الشمري, عمر سهيل المطيري, أحمد فلاح المطيري, أثير صالح الجار الله, وعد سعد المطيري, منار علي الغامدي, كل أبطالنا اللي متفوقين ودنا صراحة ندعوهم على المسرح، ناخذ صورة جماعية معهم ومع أهاليهم. فتفضلوا معنا على المسرح، الله يعطيكم العافية. عندنا بعد طالبة متفوقة. ويلكم تو ذا ستيج مريم عبد الله النجار. حياك الله يا دكتور. the role of the discussions today will be about designated institutional officer. Welcome to the stage, Mr. Craig and Ms. Hanan. Dr. Hanan, Dr. Craig, welcome.
Okay,
Thank you. Maybe we should start with an introduction
sure.
about you, Dr. Hanan, then you, Dr. Craig.
First of all, thank you for inviting me. I'm really honored to share this session with you. I'm Hanan Fan. I'm a consultant pulmonologist and internal medicine with special interest in pulmonary hypertension. I'm the DIO of King Fahd Armed Forces Hospital in Jeddah. I had a 10-year experience in the training. I used to be 6 years program director of internal medicine residency program, then 3 years program director of pulmonary fellowship, and then I was for 2 years the chairman of the local committee in Saudi Commission for Health Specialists in the Western region.
Welcome with us, Dr. Hanan, and thank you so much for giving us your time. Dr. Craig.
All right, thank you very much. My name is Craig Sapatelli. I am, just for full disclosure, I'm not a physician, but I am the Chief Operating Officer for Royal College International and Executive Director at the Royal College of Physicians and Surgeons of Canada. I have the pleasure of managing and overseeing all of the international relationships within the Royal College, and I've had the pleasure to be here in the Kingdom probably about a dozen times. And I know our relationship with Canada and Saudi dates back to probably 1975 or 1978, in and around there. So I'm very familiar with the medical education system in Saudi Arabia and the broader region. And having worked with many different countries and program directors and DIOs, I hope I add some value to the conversation today.
You will absolutely will, and we always welcome you here. Maybe we should start with Dr. Hanan. I'm not familiar with the term DIO and what does it mean and what is the role of DIO. So if you can take us through that.
Exactly. I always been asked, what's DIO? So DIO stands for Designated Institutional Official. Is the official who has the authority to speak and sign on behalf of the health institution in regards to all matters related to the training programs accredited by the Saudi Commission for Health Specialties. DIO has the administrative and operational authority to commit institution resources, enforce policies to maintain strong and effective compliance on programs. DIO is also responsible for the accreditation, the training process, and assessment of the training programs in his center under the executive rules and regulation of Saudi Commission for Health Specialties.
Dr. Craig, maybe we can zoom in to the DIO role in the training process maybe and have some of the benchmarking ideas and how we can benefit from that.
Okay, so first in Canada, we use the term program director versus DIO, but they're interchangeable. And you know, from my perspective and from my knowledge of the Canadian PGME environment, the program director is really the educational lead, the human resource manager, the program designer, the owner of that specialty program that has been entrusted with the training of those residents to make sure that at the end of their training period, whether it's 3 years, 5 years, or 7, and when they take those certification exams and licensing exams, that they are ready to practice medicine in their specialty. So it's a very important role and one that in Canada is aspired to by many residents because it allows them to take on a broader leadership role later on in their career and to leave a mark on the institution that they're working within. And it really sets them up for other advanced roles within the Faculty of Medicine, whether it's a postgraduate dean or maybe a deanship. But it's usually an entry level in Canada for that type of a career path. Your question relates to
training exactly and the training process, how they should interact with students, how we can see, for example, their exposure on the training curricula.
Right. So there's probably 2 different areas or 3 other things I can talk about. There's the educational design component. So as a program director, you really want to know what is the best learning environment for your residents? What type of learning method would be most appropriate for a different scenario? What type of feedback and how do you deliver that feedback to them is really important to make sure that the learners, the residents, are actually absorbing the material, understanding their role, and really thriving and growing in that position. They also need to create in Canada a very safe environment too. We have a lot of emphasis on underrepresented populations in Canada, whether it's the Indigenous population, people of color that are not really in the medical profession. We want to make it a harassment-free and a welcoming environment. And traditionally in Canada, it did have a bad record of harassment and bullying, so we're really working on creating an environment that is no longer tolerated, and the emphasis is on learning and not dealing with those interpersonal conflicts. So that's a real big part of the program director's position and role in Canada. And it's becoming more so with just the pressures that the system is under to address a lot of the societal needs in Canada.
So Dr. Hanan here, how we can see or how we can learn about the more of skills and competencies that DIOs should practice to streamline that training process with their residents within an ecosystem.
You mean the skills the DIO should have?
Yes.
First of all, as per the standards of the Saudi Commission for Health Specialties, is to have to be a consultant first, with a minimum of 3 years experience in the training, education, and administration. But I believe that not only that is enough. Personality is important. The appropriate attitude, to have the teamwork skills and the skills of listening, decision maker. But even though with my humble experiences in the DIO, I believe even in the first few months, I would share with you that I wanted to quit DIO. I was thinking any consultant with the experience can be the DIO. Why to suffer? But then Dr. Adila Gattan is here. She's my direct hospital director assistant for academic affairs. She said you need to have the leadership skills. So I have a lead group of program directors, and I'm really proud of. And not only to lead by giving instructions to follow, and not only forms to fill. I have attended the medical education conference lately. I attended a workshop of leadership in humility. So having this skill is unique. So having this is special. Plus that I believe that not only that, it has to come from inside. And I keep saying this in all the meetings, that all the trainers, I believe that all doctors, to a greater or lesser extent, has the responsibility of training. So I'm happy to have this opportunity to say it in the media as well, that all doctors have the training responsibility, not only for, even if who's not interested and doesn't want to teach the young doctor, still have the, must have that intuition, the intention to doing good, and not only for the center that he's working at, for our beloved country. And of course, as we are Muslims, that لوجه الله, it's for لإرضاء ربنا. So we have this deep Islamic background as well.
Yeah, you are absolutely right. How you can reflect on that, Dr. Craig?
So I'm not a doctor, I'm just a mister, first of all. But if it gets me through traffic at the end of the night easier to get back to the city, I'll just call me doctor.
Just to sit you at respect. I just upgrade you. Doctor by association.
That's right. So in Canada, certainly leadership ability is foundational to being a program director. A communicator, being able to communicate in all different types of situations, whether it's with executive leadership, resident trainees, faculty members, it's really important. Being able to implement processes and workflows and policies. It is a very heavy administrative function in Canada. And with a lot of the transformation that's happening in medical education in Canada from a time sequential based learning model to a competency based medical education model. That's been a huge shift, and I don't want to say burden or a challenge for the program directors, but it has certainly made them realize the value of communication and engagement and leadership. Conflict resolution, certainly when you're dealing with learners in a high stress environment, you're going to have to deal with conflict and difficult conversations undoubtedly. So that's really important. The other thing I think is just the administrative side. The more that I interact with program directors, they're being asked to take on budgets and do performance evaluations and run basically an office that requires an administrative role versus a clinician and educator role. So we're getting more and more requests to provide that leadership capacity in developing and delivering performance appraisals, budgets, finances, all of that kind of foundational stuff that maybe wasn't really part of training in the past. So that's been the Canadian model.
Yeah, that's absolutely a key element. When you see DIOs are operating in a training center, dealing with a lot of departments. So Dr. Hanan, here from your perspective, how a DIO can be an encourager of a learning organization or a learning ecosystem within their training centers?
First of all, talking about Saudi Arabia, we have to mention about the healthcare transformation. So all the training center, I'm talking on behalf of all DIOs in Saudi Arabia, we're going on a journey of transformation. And the Saudi Commission for Health Specialty, with its new version of the institution accreditation standards, has materialized the modern model of care into the postgraduate training, aligning with the Saudi Vision 2030 to achieve the strategic objectives of our leader, His Royal Highness Crown Prince Mohammed bin Salman. So inshallah, we're going in this journey to transform the healthcare system in the kingdom to be more comprehensive, effective, and integrated than ever before. So to support the trainers, of course, you need the support, not the DIO alone. So you need the full support of each center by its own rules. Like military hospital is different from university hospital, but at the end, the concept of having the full support of administration at all levels, without specifying the differences. So I believe it's the whole mindset change and the culture change. I believe this is the most difficult part of the DIOs nowadays in this transformation period.
Can you touch on that, Mr.
Yeah, sure. So in Canada, program directors, there's about a 6-month to a year transition leading up to when you take over a program. And that's the shadowing phase where you are partnered up with the existing program director. You're included in all of the communications and the challenges and opportunities that lay before you when you inherit the role. So there's that leading up. The Royal College has taken a lot of effort in developing program director leadership handbooks, and it's all readily available, open source on our website. A 30, 40 chapter handbook on what does it mean to be a program director in a Royal College Physicians and Surgeons of Canada training program. All new program directors are charged with attending the program directors workshop that's hosted every year in conjunction with the International Conference on Residency Education in Canada. So there's all of that building up to taking the baton and running with it. There's a lot of mentorship within the Faculty of Medicine, and I'm sure that's the same here in Saudi Arabia, where program directors and DIOs are communicating often across departments and with former and past DIOs to have that mentorship and coaching and learning. There's also a lot of trans-institutional discussions that happen across the country with DIOs and program directors to, again, learn from one another. So it's a sense of a community that's created in Canada.
Yeah, I agree. Also, for us, the program directors and all the trainers, we involve them in the workshops as well. And we do care about them mentally as well for the program directors and the trainers, and to prevent burnout, and securing their protected time and providing incentives. And empowering them in case of facing any challenges, especially when the program directors with the department director, for example. So at that level, who should interfere in that? Then it's the DIO, of course.
So I just want to touch on that, the well-being and wellness of our DIOs and program directors. As much as they care for the well-being of the residents, there is a greater emphasis now in Canada on the DIO program director's well-being, the right to disconnect, taking vacation time, professional development time, and just not always being 24/7 connected. It's an individual choice at the end of the day how you balance that out, but it is being part of the discussion and narrative now at faculties of medicine. And the provinces in Ontario and other provinces across Canada are actually adopting legislation now that is, I don't want to say mandating, but is strongly encouraging the labor force, and that includes healthcare, to disconnect and not always be connected and tethered to the phone or work.
You touched on something that is very important, which is well-being to the DIOs themselves. And I believe this is maybe one of the biggest challenges because they have to make sure of the alignments between the stakeholders with an external alliance, within an ecosystem, as you touched, 2030 vision, health transformation in the Kingdom of Saudi Arabia. And I'm sure that there is a similar story around the world. So can we address the big elephant in the room, Dr. Hanan, and tell us, for example, what is the challenges that the DIOs might face in performing their role?
Well, financial challenges is the biggest challenge, at least on different levels with the different training centers. I believe the mindset of all higher levels, they should give the academic affairs and the training center. We're talking here not only to train, the majority of the Saudi Arabia population are young people, and these young people are our human wealth. So we need to invest in providing them high quality training, because this will reflect on the best patient care in their future career. And having those young future leaders, they could work with us and be our colleagues for the best patient care. So it's not only, it's a continuous journey from education to future career.
So I think from a program director point of view, having the team around you as well to support you, in Canada we use the term program administrator, that may be the same term here, but they are the administrative support system first point of contact for the program director to help them facilitate and implement all of the changes within the program they wish to make, as well as overseeing all of the residents. And having a strong relationship with the program administrator is really key to your survivability, I think, in the role, from what I've told, and that having that weekly, daily touch point to make sure that you are on top of the program's challenges and needs is really important. So that communication with the program administrator. From a residency point of view, the program administrator also plays a very key role in that relationship. Yes, the resident will come to the program director, or they may not come to the program director because they don't want to perhaps expose concern or challenge they're having, but they may go to the program administrator and seek support from them. So it's a bit of a triad, I guess, in that.
I believe also, selecting the trainees, we do interview, but also selecting the trainers. I believe that the trainers, talking about the teachers, are the key ingredient of the training education. So selecting those who have this passion of education is important. There is a quote I read, it says, the curriculum matters little in comparison to selecting students and teachers. If those are good, any system will work fine. But if any indifferent, then any most perfect curriculum will fail to produce the result.
Maybe one final point that just came to my mind is that the accreditation standards too in Canada make it a very key point around wellness, well-being of faculty, residents, and program directors. And They want to make sure that there's protected time, that there are opportunities where they can voice grievances and have those higher level disputes addressed. You can't really sweep it under the carpet because during the accreditation process and the interviews, it will percolate to the top. And in Canada, there are several programs that do have challenges in maintaining accreditation because it is such a high bar. And you know, these challenges will rise to the surface and will need to be addressed.
Dr. Hanan, maybe we spoke about accreditation, regulation. So maybe we will speak more about how DIOs interact into that evolving, for example, healthcare industry within the Kingdom of Saudi Arabia, and I believe this goes all over the globe, and how DIOs should interact with these changes that is coming from regulatory perspective.
So again, we have to emphasize the patient-centered approach, and we need to orient the trainees about this, and also orient them about that not only the medical, to have knowledge is enough. They have to fulfill the other competencies. So there are other acquired competencies they should acquire, and we follow usually the CANMEDS framework. So having the leadership, scholarship, communication, collaboration, health advocacy, and professionalism, they will be evaluated upon all these competencies. And then also we need to encourage them for the innovation. That's part of the transformation. So we have to involve them in doing research, improvement projects, clinical pathways, and we have to involve them more towards we send them to the peripheries to encourage them to see how to manage patients before the treatment, like the disease prevention. And that's one of the objectives in the vision. And again, utilizing the technology and virtual care and e-health for the trainees. So all these, all centers in Saudi Arabia should collaborate to achieve these strategic objectives with the trainees.
If I can just add, I guess, in a Canadian context, every program director has to sit on the specialty committee at the national level. So the national level being the certification body, the Royal College of Physicians and Surgeons of Canada, so that they can interact with their peers across the country. In Canada, we only have 18 faculties of medicine. Of course, that's a small number compared to Saudi Arabia. So those committees are, again, another community where they have to sit. There's also representation on the exam board. So the linkage of the accredited standards, the curriculum standards to the exam, there's some continuity there from the program directors' engagement on those committees at a national level.
We touch point on skill set of DIOs. We touch points on the role of DIOs against external factors such as stakeholders, changes in regulations, and we touched point on internal factors, that is departments, residents. So Dr. Hanan, I'll start with you. From your point of view, what is the successful profile to fill in the DIO role, and how they should be continuing their professional development?
You mean for the future? I believe collaboration, cooperation between all centers, and to fulfill all these Saudi Vision 2030 together, hand in hand.
Okay. So I think someone who has a strong desire to create and follow a continuous quality improvement pathway in everything they do, it's very important for the characteristics of a successful program director today and in the future. I think obviously technology adoption, you can't slow down what's coming down the pipe in terms of artificial intelligence, and that's going to help. Probably in Canada, we've already had conversations around certainly the development of item banks for exams, selection of resident trainees for programs, and the placement of those residents in training programs. So I think that's going to be certainly a huge area. I would also say cultural awareness too. In Canada, we have a lot of international foreign trainees from the Middle East, from South America. It's only growing. There's a lot of mobility in healthcare in terms of resident training and fellowships. And so it's just being aware of the cultural nuances is really important. And immigration is really having an impact, I think, on training models in Canada. In some of our cities, there's a huge population influxes from different parts of the world. So that changes the patient profile that you're interacting with on a daily basis. So that's going to be, I think, part and parcel of that shift in medical training and care delivery, and certainly will impact program directors at some point. And the makeup of their program will certainly be international in Canada. There's a lot of programs in Canada that have probably 50% international representation, if not more. So it is a big part of that role, is to be open-minded and receptive to different cultures and past training programs.
I believe the financial issue and the funding. There was an idea if to utilize the agreement between the different centers. So if a center that is good in having an excellent simulation lab, then the other centers can also utilize this by the agreement and so on. If another center is good in doing conferences, then we'll send their trainees or trainers to attend in that center. So that's the idea. And it's also, it's good that Mr. Craig, you mentioned about the international standards. So also in Saudi Arabia, the centers can get the international accreditation as well. So that will facilitate the fellowship after finishing the residency program here.
Same kind of comments, but in Canada, we're a very large geographic area, so is Saudi Arabia. And one of the challenges that we have is getting practitioners to practice in small rural communities. And it's probably the same here in Saudi Arabia. So program directors looking for opportunities to have those relationships with small centers and promote mobility and potentially setting roots in those communities for clinicians, and trying to help that part of the healthcare delivery conundrum that Canada has, which is usually very underserved rural population communities, and program directors, I think, are going to be asked to play a bigger role in helping to address that in the future.
Absolutely. Thank you so much. We want to take some question from the audience if there is any. So please, in a show of hand, and they will pass you the mic. If there is any questions that Mr. Craig and Dr. Hanan can address. So until a question shows up, I have a personal question. We want to hear some stories. We hear about the hardship of residency, and I'm sure that's something that a DIO should be doing the mentor role, let's say, in that learning journey of these residents. So from your experience as DIOs or program directors, what can you share with us from these stories that can motivate residents or motivates people to be DIOs?
I believe the relationship between DIO and the trainees is important. So we need to do regular meeting with them. We at least do quarterly, but that's having all the residents of all the programs together. But now we're having this like ad hoc visits specified for each program. The DIO, and I have an excellent, wonderful deputy, Dr. Munira Sharif, and she's currently covering my work there in Jeddah. We have a good team, so we go and tackle each program. So sometimes the issues are different, and having this close relationship and tackling all the challenges differently, each program separately. This is one. The other issue, I just had an incident last month. A resident who had an issue, and then the RTP, the program director, could not handle it anymore. So the relationship between the program director and the resident. Then I told the resident, what's the issue? She said, no, I will not mention that. anyway, it's just 1 year left. She's already past 3 years and only 1 year. So what's the benefit of, it's okay, I can just bear with it. So I said, at least for your colleagues in the department, if anything in the department, in the program, it's my role as DIO to tackle it. And then she was like a bit, and then I told her, any mentor you can open to. She said, no. She will not mention to anyone. I told her, then can you mention to me? I know I'm already overwhelmed by many programs and a lot of other issues, but sometimes you need to take the residents in close proximity and take it even one by one, like the whole programs, and then each program, and then each trainee by its own. And then, so she accepted, and then that's the way how things go. That's my experience, one of the experience.
So again, I have not gone through a residency training program because I'm not a physician, but what I will say, and what is very important for our leadership team at the Royal College, is that we pay attention to the human side of learning. It's not just about the clinical academic side of it, but we want to make sure that we pay attention to the humanity side of it.
Right.
You will certainly remember, I am sure, Dr. Hannah, the mentors that you've had along the way and how they made you feel and how you were treated in that particular program. And that leaves a lifelong impression on you, not just of the trainer, but also the institution where you were doing your training. So that's really all I would add, is that in Canada, we're starting to pay more and more attention to the softer skills that are required to be a competent and productive physician.
Well, Mr. Craig, Dr. Hanan, I thank you so much. We learned a lot today. Knowing the role of the DIO and how important it is from an institutional perspective, also from fostering the training process perspective, being the, let's say, key players in creating a learning environment within the training center and within the training process and the criteria to choose program or get in an accreditation process. So thank you so much for that.
Right. If I could just say one thing, if you're interested in what the Canadian model, again, is all about, you can go to our website and download the DIO Program Director Handbook for any type of reference material that you would like to compare and contrast your program with a Canadian model.
Well, thank you so much.
On behalf of all training centers in Saudi Arabia, definitely we're gonna reach to the bright future, inshallah.
Inshallah. Before closing the sessions, once again, I will check if there is any questions from our audience.
دكتور عادل قطان.
عادل بيجيك المايك.
She's the Assistant of Hospital Director for Academic Affairs.
Assalamu alaikum wa rahmatullah. Hi, good afternoon. First of all, I would like to thank you for the organizing committee of Saudi Commission of Health Specialty for such prestigious meeting. And thanks, Mr. Greg. Thank you, Dr. Hanan. And on behalf of every DIO in Saudi Arabia, Dr. Hanan was the model representing them, and I would like to share a beautiful experience. She forgot maybe to mention that she activated the role of the institutional training committee. She divided the training committee into a smaller subgroup. That's why she, in my opinion, achieved a successful level, and she was nominated to this prestigious conference because a strategical planning, how to take care of training committee members, how to take care of residency program. In my opinion, single hands can't clap alone. I think she had both hands, her hand as well as the institutional training committee. And I believe that we are in comparison with the Canadian model because King Fahd Armed Forces Hospital and the Ministry of Defense adopted the Canadian model 7 years ago, but unfortunately we had our own because Saudi Commission has publicized the Saudi version of accreditation. And I believe together with people like Dr. Hanan in our country, we can achieve international standards soon. We can fly and to achieve not behind our crown prince, but shoulder to shoulder with our beloved crown prince to reach the top of the mountain, inshallah. And thank you again.
Thank you so much for your note. Dr. Hanan, you want to touch up on that?
I would like to thank Dr. Adila for coming all the way from Jeddah, and my colleagues also from military hospital who came specifically to attend, and all who are attending, and my parents, of course, and all the training centers, the DIOs, my colleagues. I'm just telling on behalf of everyone. And thank you for the support of Saudi Commission, and I can't thank enough everyone. Thank you very much.
We thank you as well, Mr. Craig.
Again, just to wrap up, thank you very much for inviting me here today. This is the first time I've been to the Global Health Exhibition, and it's a great experience, and I'm looking forward to next year and continuing my discussions with the Saudi Commission and our Saudi partners, and hopefully we'll have another 40 years of Saudi-Canadian collaborations in health education.
Thank you so much. Dear attendees, we will set up the stage for our next session, so we will be taking maybe 5 minutes break before we start the next session. Thank you so much.
Nice to meet you. شكرا دكتور عبد الرحمن. Thank you.
Ladies and gentlemen, we will start our next session. And for that, we would like to welcome on the stage Dr. Dina Ismail, the Executive Director of Healthcare Leadership Academy of the Saudi Commission for Health Specialties.
الله يرضى عليك. تست صوت واضح؟ So, good afternoon, ladies and gentlemen. It gives me great pleasure to be here with you this afternoon. My name is Dina Ismail. I'm the Executive Director of the Leadership Academy here at the Saudi Commission for Health Specialties. I was asked to present a skill that I think it's important for leaders in healthcare. So I thought of executive presence. We'll learn further about the skill, but since you've been sitting for a while, I thought we'll make it a little bit of an interactive session as much as possible. So what I'll do is I want to show you pictures, and I want you to say the first impression that you get when you see that picture. تمام؟ أول شيء يخطر في بالكم لما تشوفون الصورة. So picture number 1. Professional, pleasant, executive, achiever, excited, hilali, social media, narcissistic, can't hear you, angry, has something to say, to share, معصب, angry, الفريق الثاني اللي ماني بقايله اسمه، positive, happy, young, youth, professional, young, optimistic. How long did you see the pictures? How many seconds? 2, 3, 5. 3 seconds. 3 seconds you saw the pictures. Research has shown that it takes 7 seconds for an impression to be made. So you come inside a meeting, 1, 2, 3, 4, 5, 6, 7. خلاص, an impression is made. You're nice, you're professional, you're friendly, you're angry, you're unpleasant. An impression is created. That's why it's important to have what we call executive presence. يسمى بالعربي الحضور القيادي أو الحضور التنفيذي. The book by Sylvia Ann Hewitt from Harvard talks about her research in executive presence. الكتاب مترجم في جرير اسمه الحضور التنفيذي. So what did she says executive presence is made of? She says that executive presence is made of 3 competencies. 1, gravitas, which makes up 67% من حضورك القيادي. Communication makes up 28% of your presence. And finally, 5% for your appearance. So this combination creates الحضور القيادي or your executive presence. So let's take one by one, starting off with gravitas. Gravitas is a Latin word that means weight, ثقل. الترجمة العربية لها الثقل. شفتوا لما نقول أحد ثقيل، راكز، ما يهزك ريح. So this is the gravitas. This is what we talk about how you react, how you act, how you make an entrance when you come into a room, how you make eye contact with people, and how you make mindful gestures أو إيماءات. And I've put for you pictures of the late foreign minister of Saudi Arabia, الأمير سعود الفيصل الله يرحمه. Why? Because I want him to be your reference point. How would سعود الفيصل الله يرحمه will react? شفتوا هذا الثقل? This is what we're talking about. That gravitas and weight. Amy Cuddy, Professor Amy Cuddy from Harvard Business School, she talks in her book Presence about how your body language can affect your confidence and feeling of power. In her studies, she measured 2 hormones. هرمون التستوستيرون، هرمون الcourage، هرمون الstrength، الpower، feeling of power. And another hormone, which is the cortisol hormone. هرمون الفear، anxiety، التردد، الخوف. She measured these 2 hormones at rest and then got the subjects, put them in a room and asked them to sit in positions that she called high power poses. وضعيات سمتها وضعيات قوة. And you could see them sitting in these positions. She asked them to sit for 2 minutes, دقيقتين فقط. And after that, she went back and measured those hormones. And she found that testosterone was increased by 20%. هرمون الشجاعة، الإقدام، القوة increased. Hormonal cortisol has decreased by 25%. الخوف، التردد، الانxiety all went down by 25%. The same subjects, she asked them to sit in low power positions again for 2 minutes. And she found that testosterone, the hormone of confidence and strength, decreased by 10%, while the cortisol has increased by 15%. So زادت الانxiety، الخوف، التردد, just sitting in that position for 2 minutes. After that, she came and called them, all of these positions, to power poses. So these power poses, sitting in them for 2 minutes will help increase your testosterone, the feeling of confidence and strength and power, and will reduce your fear and anxiety. The first pose that she talks about is the CEO pose. Is when you stand at a table with your hands spread around that table. Sitting in this position for 2 minutes will help increase your confidence and reduce your anxiety. And you could see here Angela Merkel, the former Prime Minister of Germany, you could see that she looks like she's having a power moment. She's leading that discussion from the position that she's posing. Another position is the Superman and the Wonder Woman pose, where you stand with your hands around your waist. طبعاً في مجتمعنا هذا البوز غير مقبول. واقف ومتخصر لي ما نقبلها احنا. So the trick is that you could use this pose to help boost your confidence or reduce your anxiety with a few tricks. So what you could do, for example, let's say I'm preparing for a presentation. So I could simply walk around doing this pose. So I'm tricking my body that I'm in a power position, increasing my testosterone level, and reducing my anxiety. Also, Professor Amy Cuddy, she says if you're having an interview, going into an interview or something major presentation, you could go to the toilet, الحمام الله يكرمكم, and just stand there in front of the mirror for 2 minutes. This will help trick your body that I'm in a power position now, raise your confidence, reduce your anxiety, and you're ready for your interview or presentation. Another position, victory pose, وشفناه أمس 5 مرات. So the victory pose, it gives you that feeling of courage, power. So this position, we see it a lot with athletes. The researcher has found even blind athletes who were blind since birth did this when they won. So innately they did it. We see this a lot. We do it, إحنا non-athletes. We do it sometimes when we make an achievement. So when you hold a certificate, or for us ladies will hold a driver license, this is a power pose, a victory pose. I achieved something. When someone, قبل شوية, those who held their certificates. So it's a power pose as well. So these are what we call victory and power poses. Another point that you need to notice, part of your gravitas, is your eye contact. التواصل البصري حقك. So التواصل البصري sometimes can be too much. How would you feel if someone is looking at you that way? Feels dominance, lack of respect, threatening, intimidating. Kind of scary, صح? Sometimes you'll see this, you'll say this is very extreme. But sometimes we do this. Me being a mother, I do this a lot with my kids. I give them the look. وش تبغين أقوم أصب قهوة? What do you want exactly? So sometimes we do this to threaten someone, to look at someone with a look, to make them feel threatened, to make them feel I'm dominant here. Sometimes it can be too little. When it's too little, what do you think? What's the reason behind it? Or how does it look? Intimidated, afraid, shy. Or sometimes people will see it as impolite. In our culture, we see it shyness, خجول, حياء, يغض البصر. Other people who do not understand our culture might see it as impolite, might see it as poor attention. Us working in healthcare in multicultural colleagues and teams, we need to make sure people understand the difference, the different eye contact that we have. Part of your presence, and a lot of us in hospitals, in our working environment, we do a lot of meetings. So your meeting presence is important. So it's important for you to take your proper place within a meeting. So people see you in that meeting. Understand the culture of your organization. Know where you need to sit. Always come early to have a good seat when sitting in the meeting room. Because a lot of the time, we come into meetings, we do not say a word. We don't have a chance to talk. I'm not presenting. There's no discussion, so I don't talk. At least let me sit in a chair that gives me the maximum presence that I want to create. Also, a personal point of advice that I will give you, avoid multitasking in meetings. And especially the females, I always see a lot of females, they will multitask. And here, who's multitasking? The lady. A lot of females tend to multitask in meetings to show that I'm a multitasker. أحياناً كذا أنا مكروفة. شوفوا قديش أنا قاعدة أشتغل لكم. However, sometimes it's read wrong when you multitask in meetings. It's read that you cannot manage your time, you cannot manage your team, you cannot manage your work. And personally, I learned it the hard way. I used to always carry my laptop to work, to meetings, And one day when I wanted to hold a project, I asked my boss, I want to hold that project. He said, but Dina, You're doing your emails in the meeting rooms. So you're too overwhelmed. So I lost an opportunity because I thought they will think أنا بطلة. But actually, it came back to me. So avoid multitasking. Even لو في حريقة في المكتب, come, sit, enjoy the meeting, and then leave. Let's do كذا a quick exercise. So imagine you're in a meeting room. You're part of a committee. You're not the chairperson. طيب, the chairperson is sitting on chair A. We have windows, we have a screen, and we have a door. We have chairs all over, and there is no co-chair to the meeting. كلنا سواسية. في chairperson sits at A, والبقية كلنا members. Where would you have a look at the alphabet? And I'll ask you to choose which is the best seat on the table. Okay? Have a look for a minute. Okay? قررتوا? You chose your chair? So how many of you said B? Raise your hand. Right. How many of you said C? Raise your hand. How many of you said E? Right. How many of you said D? طيب. So the best chair on the table is chair B. We'll give you the reasoning why. أولاً, chair B is in front of the door. So الداخل والطالع I can see. It gives me a better view of the room, better control. احنا we wanted to be who's our reference point? سعود الفيصل. So imagine I'm sitting in C and the door behind me. So whoever enters, I'll do. سعود الفيصل would not look like that. So you want to have complete control. So if someone enters, you could simply see them and react appropriately. So this gives you more control. Plus, another plus for B is that you're sitting close to the decision maker. Sitting close to the decision maker gives you an opportunity to comment, and your comment is heard. It gives you an opportunity for everyone is presenting towards that direction. It gives you an opportunity. People will assume you have power because you're close to power. شفتوا كيف بقالة حارتنا تصير بقالتنا؟ مسجد الحارة يصير مسجدنا؟ ما هو بمسجدنا. بس because it's close. So when you're close to decision making, people will assume you have power in decision making. شو نقول حنا صيت غنى ولا صيت فقر؟ So let people assume you have power, although you don't have power, just by selecting the best seat. Deborah Gernfield, she's a professor at Stanford University. She has a book titled Acting with Power. In her book, she talks about how leaders can act. She says leaders need to act authoritative, and she called it play high. Okay, play high, being an authority. And also they need to play low by being approachable to people, close to people. She called it playing low. Okay, so تقول a leader needs to know how to play high and play low. So how does playing high looks like? So in her book, she explains how playing high looks like. So, first of all, a leader playing high has an expansive posture. They take space when they sit, when they walk. Okay? So لما they walk in a hallway في المستشفى, they walk in the middle because they take the maximum space. Also, they have what we call a still head. حركة راسهم قليلة. They don't move a lot. الموفمنت حقتهم قليلة. They speak incomplete sentences. جمل كاملة. Because when a leader talks while he's playing high, أنتم كلكم جايين تحضرون لهذا الليدر وياخذ راحته في الكلام. يسترسل وجملة متكاملة. So they're very slow in the way they talk because they feel that they own the time of the people that are listening to them. They hold eye contact with people. They look at people when they talk. They move slowly and they slow down. حركتهم تكون بطيئة وعلى الراحة ورايقين. And they have no visible reactions to what others say. عندنا حريقة. طيب هدوا. So they're very cool. شفت لما احنا قلنا ثقيل وراكز. So they're very cool in their reaction. On the other side, she says that a leader needs to play that role, also needs to play low. So how do you play low? Well, it looks like that you hide yourself. So I stay away. I hide. I don't want to be seen. I minimize my space. So بدل ما أمشي بالنص السيب أمشي على الطرف السيب. I speak quickly. لأن شكراً أعطيتوني 5 دقائق من وقتكم. أنا مرة ممتنة بعطيكم بسرعة presentation. They speak very fast because they don't think that they're worthy of this conversation. They speak in incomplete sentences. جملة متقطعة. Because they're waiting for the reaction of the other person. So, هي قاعدة الحين تقول we need to play high I play low. When do I play high and when do I play low? So, for playing high is to reinforce your position. So reinforce your position when I want to play a role with my peers, so I'm a leader, so I play high. This is my position. Sometimes you do it when authoritativeness is called for. So let's say for example في مشكلة صارت برا مكتبك تطلع أنا المدير هنا وش اللي صاير؟ You play high. However, you play low to show respect. And I'll show you now what I mean by showing respect. You play low to build rapport. So أنت شخص تبي تتعرف عليه. I play low. I build rapport. أبدأ تواصل بفعالية مع الآخرين. And finally, I do it to lift someone up. I want someone else to shine. So I play low. حتى لو أنا مديرة. But at this moment, let them be high, I'll be low for their sake. Okay? Here, we have a picture of Trump and President Obama. President Obama was still in office. So a picture from the White House. President Trump is president-elect. So President Obama is playing high or low? High. Expansive posture. معبي الكرسي حقه وجالس you could see he has an open gesture. بينما you could see Trump has a collapsed presence, minimizing themselves. So أقل. You could see them minimizing. Plus you could see his hand in front of him. So he's minimizing himself. طيب هنا Trump is playing high or low? He's playing low. You could see him playing low where he is leaning towards الملك الله يحفظه. His head is looking down. He's smiling with his eyes below. because he is with someone who's older than him by age. He's a royalty and he's a president-elect. Plus, he's in Saudi Arabia, so he's in someone's home. So he feels I need to play low. I'll show you a video clip about how can a leader plays low in certain situation. So the video clip is from King Faisal Specialist Hospital, Jeddah. Al-Amir Khalid al-Faisal, he's the Prince of Mecca region, and he's just leaving the hospital. The CEO of the hospital, he's not in this frame, he will show in a bit. He would be the guy wearing a lab coat and then wearing a mask over him, okay? أبغى نشوف الفيديو and then I'll tell you a little bit about it. So هذا ال CEO حق المستشفى تشوفونه ظهر. So was he playing high or low? Low. Hiding himself, minimizing himself, hiding لبس كمامة. Hiding himself, minimizing جلست على جنب. So this is how a leader plays low. لأن دائما يجيني السؤال سهلة high. We know how we play high. How do we play low? When do I play low? I'll show you another clip. This is from King Salman, Allah يحفظه, leaving King Faisal Specialist Hospital, Riyadh. And I want you to see the Crown Prince where he's standing. The second video, please. Sitting to the back, collapsed, not taking space. He's the Crown Prince and the Prime Minister, and he is the Minister of Defense. However, he was playing low in the presence of his father. So playing low. Even when the king moved, he turned around, وينك? أنت وراك. I'm behind you. So this is how a leader plays low. We select the appropriate situation that I don't need the spotlight. The spotlight can go to someone else. So we talked about gravitas, and let's talk a little bit about communication, which makes up 28% of your executive presence. So communication is how you speak. كيف تتكلم؟ كيف تتواصل مع الآخرين؟ Know your tone and speed. اعرف التون والسبيد اللي انت تتكلم فيها مع الآخرين. Also, your volume. Your volume needs to be loud enough where people can hear you, and however, not too loud that causes people headaches. So we need to know the balance. I need to know the speed that I need to talk with. A lot of people tend to talk too fast, and especially most of Saudis or who non-native English speakers, it's not our mother tongue. We're not used to it. And a lot of times, some of the words that we talk, they're not very clear. So take your time talking and presenting. Watch for vocal fillers. Vocal fillers are, you know, why do we have the vocal fillers? The vocal fillers are helping us get the next sentence from our brain. So the trick is simply pause. توقف عن الكلام. And be comfortable وأنت تتوقف عن الكلام. So talk, talk, talk. نقطة. Talk, talk, talk. Period. كمل الجملة حقتك. نقطة. And talk. أحيانا كثيرة we say عشان كذا أطلع الكلام. But شوية مزعج. Distracting to people. So the way to do it is simply pause. When you're presenting, you would need to practice on your presentation. Especially when it's your first time presenting, if it's an important presentation, practice, rehearse. A lot of the speakers that we see them on podiums, they rehearse. ترى مو فنانين زمانهم. Everybody practice and rehearse. And when you practice and rehearse at home, practice in front of a mirror. Or practice with a high voice. So you can listen to yourself. You can look at yourself. Or sometimes if you have someone that can record for you, you record yourself and criticize yourself. Fix what needs to be fixed. Part of your communication is gestures. إيماءاتك. الإيماءات or gestures help you to be less robotic. Helps you not to let people get distracted with your hands behind your back. Because usually research has shown that people do not feel safe when someone is talking this way. They always feel suspicious that they have something behind their back. That's why as soon as you meet someone, you say this, to show them I have nothing in my hands. It's an innate feeling that humans have. So always have your hands in front of you. Have them within your chest area, محيط صدرك. Not too high, not too low. Find the best position for your hands. Using your hands can be your PowerPoint when you don't have a PowerPoint. So it helps people receive your message. Also, you could use your hands for sometimes counting. So I'll tell you 3 skills. 1, 2, 3. It helps people remember and embeds the information better. However, if the information that you're counting is more than 5, do not use your hands. خلاص, it doesn't work because you will get confused and people will get confused. So it's just 5. I want to show you this clip from the Minister of Information Technology and Communication, the Saudi Minister, المهندس عبد الله السواحة. He's an excellent speaker. I want you to look at his gestures. مو لازم نسمع الكلام, but I want you to see how many gestures he's used in this short clip.
A $3 billion stimulus fund. Fast forward today, 18 months, from 1.2 million homes to 2 million homes.
طيب, I'll repeat it again just for the sake of you hear it all. شغلة please الفيديو.
A $3 billion stimulus fund. Fast forward today, 18 months, from 1.2 million homes to 2 million homes. Internet speed have quadrupled, and today we're above the global average. And this is when we genuinely said, now it's the foundation to talk about transformation.
So tripled, quadrupled, the past, the future. Now we can say. So he used a lot of gestures to emphasize the points that he wanted to make. So thinking about our executive presence, we said we have 3 components. Gravitas, which is the majority of our presence. Communication, which is the second part, 28%. And then appearance. كم? How much do we spend on our appearance? Time, money, وشغلة. A lot. However, it's not really what impacts your presence. صح, it plays a role. And a lot of the times, we were impressed by someone, as soon as they talk, it inflates, it disappears. So it's good to have the appearance, but it's not the majority of things. A lot of people say, no, I need to wear the brand watch, the brand bag. No, it's not that. It's how you present yourself, how you talk, how you communicate. However, I don't want to go through the do's and don'ts of appearance because all of us working in healthcare, we know that. However, I want to emphasize a point that you are a role model of how you appear. You are a role model of how you look. Remember these trending clothes that Princess Mohammed wore and it became sold out? Because simply, he is a role model to a lot of the people. And automatically, he wore something everybody wanted to be like him. To bring that point, that I want you to know that whatever you wear, your students will notice, your interns, your colleagues, your employees, your leaders as well. So you want to look right. You look for the position. And with that, we conclude our presentation. Thank you very much.
Ladies and gentlemen, thank you for tuning in to our second discussion panel of the day, titled General Secretary's Discussion. Leading the discussion panel, we welcome to the stage Professor Aus Shamsan, the Secretary General of the Saudi Commission for Health Specialties. We also welcome to the panel Professor Hussein Al-Frehi, we welcome to the panel Professor Abdulaziz Al-Sair. We also welcome to the panel Professor Ayman Abdu. Professor Aus, you can lead us away.
السلام عليكم ورحمة الله. Good morning everyone. أحب أني يعني أستأذن من جميع الحضور، راح يكون اللقاء باللغة العربية. For those who are non-Arabic speaker, I think there is translation devices you can refer to. الحقيقة يمكن اليوم هذا يوم بالنسبة لنا تاريخي في ظل الجلوبال هيلث، وفي ظل هذا المؤتمر الذي يظهر الصحة على أعلى مستوى عالمي، ومن المكونات الرئيسية أعتقد يعني يمكن على مستوى المنطقة من أوائل المكونات التي ساهمت في تنظيم الصحة هي الهيئة السعودية للتخصصات الصحية، وعلى مستوى العالم تعتبر تجربة فريدة، بحيث تكون هيئة واحدة زوت جميع التخصصات الصحية تحت مظلة واحدة، تجربة غير مسبوقة في العالم، وممكن تكون من خلال هذا الملتقى نصدرها كتجربة عالمية. البدايات سنة 1992 1413 للهجرة، مرسوم ملكي موقع من المغفور له الملك فهد بن عبد العزيز رحمه الله. في بدايته في المادة الثانية ذكر بأن الهيئة السعودية تهدف الهيئة إلى تطوير الأداء المهني الصحي وتنمية وتعزيز المهارات وإثراء الفكر العلمي والتطبيق العملي السليم في التخصصات الصحية المختلفة، وسرد 13 اختصاصا للهيئة لا تكاد توجد في مكان واحد. مع البداية وفي ظل تلك الفترة سنة 92 إذا عدنا بالزمن، ومع التأسيس، ومن ثم بداية التقدم في هذا المسار، حدثنا بروفيسور حسين الفريحي عن البدايات وكيف تدرجت وما هي التحديات وكيف استطعتم أن تتجاوزوها في تلك الفترة. تفضل.
بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. أشكركم بداية على هذه الدعوة، وأرجو أن يكون اجتماعا موفقا ومفيدا. الهيئة كما تفضلت هي انطلقت يعني تأسيسا عام 1412، بدأت تباشر العمل الفعلي تقريبا بعد ب3 سنوات، وكان الأمين العام الأول الأستاذ الدكتور إبراهيم العريني هو اللي بدأ العمل، وأنا التحقت بالهيئة عام 1397 هجري، تقريبا على 2000 ويمكن 1997 ميلادي. الهيئة كانت بالبداية يعني صغيرة جدا وضعيفة جدا، وكانت بالفعل عند البداية يعني معرضة لأنها يعني تنتهي. كان عدد موظفينها ما يتجاوزون 30 موظف، وميزانيتها ما كانت تتجاوز 6 ملايين، دخلها كان ضعيف تعتمد على الدخل الذاتي، ولولا الله أنها ورثت يعني مبلغ لا بأس به من الصندوق الصحي المشترك اللي كان تقاسما بين الجهات الصحية المختلفة، لربما أنها لم ترى النور يعني. فبدأنا، وكان بداية عندما جيت الهيئة كان العمل بادئ بالتدريب تقريبا، كان فيه يمكن 10 أو 13 مجلس علمي، جلسة علمية فقط، وهذه كانت هي عدد التخصصات الموجودة. المتدربين ما يتجاوز عددهم 1500 متدرب يعني فقط، بالتخصصات الكبيرة: الباطنة، الجراحة، الأطفال، النساء والتوليد، وهكذا. على مستوى التصنيف والتسجيل ما كان بدء إلا في تصنيف الأطباء الاستشاريين تقريبا فقط. أما بقية الجهات ما كان فيها، لم يكن فيها أي تمثيل للجهات الصحية غير الطبية. لم يكن فيها تمثيل لطب الأسنان، لم يكن فيها تمثيل للصيدلة، للتمريض، المختبرات. فكانت تقريبا فقط يعني تعتمد ذاك الأيام على الأطباء والتدريب المجال الطبي وتصنيف الأطباء الاستشاريين فقط. التسجيل لم يبدأ أبدا. فكان يعني البداية صعبة. يعني نريد أن نطبق بقية مهام الهيئة، نريد أن نطبق التصنيف والتسجيل على أوسع نطاق، الإمكانيات محدودة، عدد الموظفين قليل. فبعد مشاورات بدأنا بالتدريج. يعني بدأنا أذكر يعني بتصنيف الأطباء كمجموعة كلها، وبعدين شيئا فشيئا حتى أنه دخل التمريض. المجالس العلمية أعتقد أول مجلس علمي غير طبي كان طب الأسنان، هو تقريبا المجلس اللي تلا طبي. وبعدين على توالت المجالس توسعنا في التدريب، توسعنا في التصنيف والتسجيل. بدأت الهيئة يعني شوي يعني تبرز، بدأت الناس تسمع يعني عن وجود الهيئة الصحية. طبعا كان في الأول التصنيف والتسجيل جابه يعني رفض من بعض الجهات، ما كان الناس متعودين ان احد يجي يعرضهم الامتحان يقيمهم ويحدد مستواهم ويحدد درجته المهنيه، فما كان يبغون. وبالذات في منطقه مكه المكرمه كان في يعني رفض تام يعني. وظلت الهيئه تحاول وتمارس، طبعا ما عندها اي قوه يعني تفرض وجودها. صحيح ان في قرار يعني في نظام مسنود بمرسوم ملكي في لوائح، ولكنه ما في ذاك القوه لها. وبعدين يعني بدأنا احنا ننشر شيئا فشيئا عن من نمسكهم مخالفين، اما شهادة مضروب معطوبة او احد غير كفو ويمارس. فبدت الامور تبين للمجتمع، وبدت يعني الناس تسمع عن الهيئة. ومن حسن الحظ يعني في يوم من الايام يعني عرفوا انه في هيئة بس يعني يدها قصيرة يعني. فطلعت انا وتكلمت قلت له نعم احنا نعرف ان في اطباء غير مؤهلين غير كفو، الهيئة لم تؤهلهم ومع ذلك يمارسون يعني، وفي غير وغير وغير وغير. فجاء امر ملكي بانه يعني ينظر في الامر، وشكل لجنة على مستوى عالي من الصحة من الداخلية ومن اعتقد من جهات بعد اخرى يعني. انا كنت فيها ممثل الصحة وممثل الهيئة. فذيك الايام يعني صدرت توصيات انه اول شيء الاطباء السعوديين تعيين ترقيات كلها عن طريق الهيئة، الاجانب تصنيف تسجيل كله عن طريق الهيئة، ويربطوها بتجديد الاقامة ومنح الاقامة. فمن هنا صارت الهيئة يعني يدها طولية. بالمنطقة الغربية قيض الله انه صار في مشاكل، صار في اخطاء طبية على وجود رحمة الله عليه اسمه الملك الامير فواز. وقال طيب احنا نسمع عن بالرياض الناس يقيمون ويصنفون، قالوا بجد لا، ان الهيئة زي ما تقول رافضينه يعني ناس معينين. فصدر امر ذاك الايام انه الهيئة هي للمملكة، زي ما هي تعمل بالرياض بجدة بالحدود الشمالية بكل مكان تعمل بجدة، ومن بعدها عاد دخلت جدة تحت التصنيف والتسجيل. اما التدريب كان منتشر في كل مكان. التدريب توسع يعني تدريجيا، وبدأنا بالتخصص الدقيقة يعني عن طريق لجان علمية، وامتد التدريب إلى أن وصل قبل ما أترك الهيئة عام 2010 إلى حوالي 67 برنامج. عدد المدربين صار عدد كبير. التصنيف والتسجيل كان شامل لكل يعني الجهات. ومن هنا عاد يعني بدأت الهيئة عاد الدور، بدأ وضعها المالي يتحسن لأن بدأت تعمل، زاد عدد الموظفين، زاد الدخل، تحسن الوضع يعني. وبعدين عاد الحمد لله كان همنا أننا نحاول يعني أن نركز الهيئة حيث يكون له وجود كيان تبقى على خارطة المملكة العربية السعودية إلى الأبد. فكان المقر هو المنشود يعني. فحاولنا، ما عندنا أي إمكانات، حاولنا أرض من الدولة. رحت أنا العياف الأمير عبد العزيز بن عياف، ما قصر، رجل كريم وبشوش وقابلنا، قال أن تبغون مقر يعني هيئة صحية، ما عندي، أعطيكم 2000 متر تبغون وبعطيكم بنبانة وكذا. قلت بنبانة أنا عندي هيئة تعتمد على ناس متطوعين أعضاء لجان، تبي واحد يجي من الخشم العان يجي البنبان ونعطيه 500 ريال 300 ريال، ما هو بجينا الناس، هذا تموت الهيئة كذا. ما يصلح. وش الحل؟ قلت الوزير رحمة الله عليه ذاك الأيام كان أستاذ الشبكشي ما في إلا غدين، حنا الآن حي سفرات نروح للملك سلمان ونطلب منه انه يعطونا ارض منحه بحي سفرات بالمكان اللي حنا فيه. والله اخذنا موعد انا والوزير ورحنا لسمو الامير اللي هو الحين خادم الحرم بين الشركه الملك سلمان، وقبلنا بصدر رحب وكان متفهم، وقال على طول قام كلم المسؤول عن المركز المشاريع بالحي اللي هو الدكتور عبد اللطيف آل الشيخ، وقال له الموضوع كذا 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 انظروا في الامر. إيه. فبدينا عاد مع الدكتور عبد اللطيف، قال لنا هذا حي ولا يسمح الا بالهيئات ذات الصبغه العالميه او الاقليميه. انتم وش صبغتكم؟ قلت احنا اقليميه، احنا نمثل العالم المجلس العربي وحنا لنا علاقات مع الكليه الملكيه وكذا. قال اريد اثبات لهذا الشيء. انا من اجيك اثبات؟ قال لازم تجيبون تأييد موقفكم من وزاره الخارجيه. كيف نصل ذاك الايام كان سمو الامير الملكي سعود الفيصل، كيف نصل حسين فريحي الضعيف الى سعود الفيصل؟ فبحثنا كيف نصل له، قال والله في اسم واحد حمد الفارس هو مدير مكتبه يقدر يوصلكم اليه. ايه قلت الحمد لله الدكتور عبد الله الفارس صديق وزميلنا بجده، يا دكتور عبد الله قضيه كذا وكذا. كلم اخوه قال يعدون لك مذكره يعطونا اياه وانا يعطونا وقت. الامير سعود ما يسمع لي وعنده مشغول دائما وكذا، لما نطلع بالطياره يكون عندنا وقت اعطيه الطلب بالطائره. لحسن الحظ كان الامير سعود متفهم جدا جدا، وكان عنده زي ما تقول بعد يمكن تحيز معانا شوي. قال لعبد الله اعد خطاب كما ترى ووقع عليه. لما قدمت له على لطيف آل الشيخ قال انا متاكد اللي عد الخطاب هذا انت ما بهم. قلت والله يا ابن حلال اللي جاينا من عنده ولا اعرف عن محتواه الا شفته انا. وبعدين اعطونا عدل الارض يعني. فبهذا اختصار تقريبا عن يعني الهيئه وتاسيسها ونشاتها
يعني الله يحفظك. شكرا بروف حسين. يعني البدايات هذه الحقيقة توثيق هذه الرحلة جدا مهم، لأنه مسألة تجاوز الصعوبات واللي تفضلت فيه كان الهدف والدافع هو فعلا الإخلاص تجاه المهنة. يعني هذا الإخلاص تجاه المهنة هو الدافع الأساسي. وزي ما تفضلت جميع المشاركين من الممارسين الصحيين في أعمال الهيئة للقيام والنهوض بأعمالها واختصاصاتها كان كله وما زال هو في صبغة العمل التطوعي، لأنه كل الممارسين الصحيين يستقطعون من وقتهم وقت أسرهم من أجل دعم هذه المهن. يمكن لو أنتقل لبروف عبد العزيز بعد المرحلة هذه وبعد ظهور الهيئة وظهور القيمة المضافة التي تضيفها الهيئة للممارسة ولتطور التعليم الصحي، وأصبح عدد المشتركين في الهيئة كثر، وأصبح المنتسبين إلى الهيئة كثر، والمسجلين في الهيئة كثر، سواء كان طواعية أو كان بإلزام. تطلب الأمر إلى أنه يصير في آليات للعمل وظهور أنظمة مؤتمتة تستطيع أن تحتفظ بهذه السجلات. فالبداية هنا يعني ممكن تكون البداية لبداية ظهور اللي قد نستطيع أن نسميه بدايات التحول الرقمي، أو ظهور الأنظمة التي ساعدت على تأسيس والاحتفاظ بسجلات ما زالت نرجع لها، بالإضافة إلى عمليات الاستدامة في الهيئة. فحدثنا عن هذه النقلة التي هيئت يمكن الهيئة وصارت بعد ذلك من أكثر الجهات مستعدة إلى الانتقال إلى مراحل متقدمة في التحول الرقمي.
بسم الله الرحمن الرحيم. سعيد جدا بوجودي معكم في هذا المساء، وأشكركم على الدعوة، وأرجو أنه هذا الحوار يكون ثري ويعطي فكرة للمستمعين الأخوان الحاضرين عن تاريخ الهيئة. أنا قبل شوي وأنا قاعد هنا أقول دكتور حسين، دكتور أيمن وأنا نشكل 28 سنة من عمر الهيئة. أنت يمكن تقولون 25 بس هي 28، لأنه كأمنا عامين 25، بس أنا كنت مساعد الأمين العام 3 سنوات، فبالتالي يعني 28 سنة. الحقيقة يعني المثل اللي يقول يعني لا عطر بعد عروس، أنا أخذت الهيئة بعد الدكتور حسين، وأبو محمد يعني
عروس هذا اسم رجل ترى. إيه عشان العلم المثل هذا عروس اسم رجل.
نعم. أبو محمد يعني ما في شك يعني أبلى بلاء حسنا في الهيئة، أنا كان لي فرصة أني أعمل معه 3 سنوات كمساعد، ولذلك أعتقد أنا كنت يعني مهمتي أسهل من مهمة الأمنا اللي جو بعد كذا، لأن الحقيقة تعلمت الكثير من أبو محمد، وخبرتي 3 سنوات في الهيئة ساعدتني كثير في عملي كأمين عام. فالحقيقة كانت ما في شك يعني بدأت على أسس قوية، انضباط، إصرار على الكواليتي، وبنفس الوقت كانت الهيئة يعني فاتحة ذراعيها للآخرين واحتوائهم. يعني كما يمكن بعضكم ما مر بهذه التجربة، بس بداية الهيئة ما أقول إنه كان في أعداء، بس كان في ناس يعني يتكلمون بطريقة يعني وش الهيئة هذه اللي قاعدة تبغى تفتش علينا ولا تطلب منا أن نسجل أو نصنف. يمكن بعض المراكز الطبية الكبيرة في المملكة كان لها نظرة مقاربة، ليس ضرورة المسؤولين فيها ولكن ممكن المنتسبين أحيانا. فما كان الحقيقة الأمر سهل أبدا، ولكن أنا أقول الإصرار على الكواليتي والنوعية ما في شك هو اللي خلى الهيئة تصل إلى ما وصلت إليه الآن. بالإضافة إلى ذلك أنه كنا كلنا ننظر بأنه كل واحد من الفريق الصحي هو الحقيقة جزء من الهيئة. ونعتقد مع الوقت ولله الحمد الهيئة يعني استطاعت أنها تصل بأن الناس تشعر هذا الشعور. يعني كل شخص ممارس يعتقد أو يشعر بأنه عضو في هذا الكيان الكبير، هذا الكيان الوطني الكبير. فهذا الحقيقة سر نجاح ما في كلام يعني. الحقيقة لما بدأت أنا عملي في الهيئة كان عندي فكرة زي ما قلت لكم قبل عرفتها، وما انقطعت عن الهيئة لأن في لجان معينة وكذا. لكن لما تكون مسؤول أول يختلف الأمر. ففي أشياء كثيرة ما شاء الله تبارك الله كانت مرتبة، وأي مؤسسة يعني هي فترات في فيز 1 فيز 2 فيز 3، وكل يعني فترة لها رجالها أنا أعتقد ولها إمكانياتها. يمكن الدكتور حسين بدايته، دكتور إبراهيم العريني الله يذكره بالخير، يعني أتوا في وقت صعب الحقيقة، صعب من ناحية أنه مؤسسين ما في أنظمة، ما في قوانين، ما في شيء، مثل ما قلت قبل شوي كل واحد ما يبيهم، ما في وفرة مالية. بدت في السنوات الأخيرة من أيام الدكتور حسين الحمد لله الأمور تتحسن يعني ماليا. أنا جيت أعتقد أني جيت في وقت ذهبي بالنسبة للناحية المادية في الهيئة. وأرجو إن شاء الله إن استغلينا هذا واستفدنا منه يعني لصالح تطوير أعمال الهيئة. من الأشياء الرئيسية اللي كانت هاجس للجميع موضوع التصنيف والتسجيل. يعني الدكتور حسين تكلم عنه أول، ولكن التصنيف والتسجيل مع الوقت نما وعدد الممارسين كبر كثير، فعملية تصنيفهم وتسجيلهم كانت الحقيقة مهمة شاقة وصعبة. كانت الطريقة زي أي مؤسسة أخرى، يعني العمل يدوي، ما في يعني موضوع الإلكترونيك ما هي كثير موجودة كذا كويس. موضوع يعني العمل الإلكتروني وعن بعد ما هو موجود كثير. فطبعا وضعنا الخطة الأولى للهيئة اللي هي الخطة الخمسية، وكان من الأولويات الحقيقة هو التحول الرقمي. ووضعنا نصب عيوننا في التحول الرقمي طبعا كل أعمال الهيئة، ولكن كان الكور الرئيسي أو الشيء الرئيسي اللي نبغى نركز عليه موضوع التصنيف والتسجيل، لأنه الحقيقة يعني خدمة كانت تحتاج أن نطورها وبسرعة. من فضل الله سبحانه وتعالى يعني توفر الإمكانيات، توفر الشباب، تعاون الجهات، ستيك هولدرز كلنا معنا، يعني كان في تعاون كبير جدا ودعم غير محدود. يعني أنا أعتقد التحول الرقمي نقل الهيئة نقلة نوعية كبيرة، وأصبح التسجيل يعني انستنت على طول. ممكن أنت الآن إذا أمورك يعني كاملة تسجل اللحظة نفسها وتسلم. في السابق كانت تأخذ، الدكتور حسين يعرف هذا الكلام، دكتور أنت ما مريت إلا بالفترة يعني الرقمية، فأمورك كانت أسهل شوي. حصل إنه يعني كان في معاناة كبيرة بالأخص من الممارسين اللي خارج المملكة. يتم التعاقد معه طبعا، وإذا تعاقدوا معه يجي المملكة يشتغل. كانت الهيئة إيش تسوي؟ طيب هذا واصل في عقد عمل معه، محسوب راتبه على الجهة اللي جابته، فلا بد إنه يعمل طبعا. فكنا نعطيه ترخيص أو تسجيل مؤقت. أوكي؟ التسجيل المؤقت الحقيقة زين وشين، فيه مشاكل، لأنه ممكن أحد من هذول المسجلين المؤقتين يثبت أنه ما هو كفء للممارسة، وتبدأ المشاكل. صاحب العمل يتضرر والممارس يتضرر وكل يتضرر. فالتحول الرقمي الحقيقة من فضل الله يعني خلانا نستطيع بأنه الممارس يسجل ويصنف وهو في بلده قبل الوصول. هذه الحقيقة يعني كانت نقلة ويعني محط ارتياح من جميع من يتعاملون مع الممارسين الصحيين. طبعا بالإضافة إلى سرعة إنهاء إجراءات الممارسين اللي داخل المملكة طبعا. فهذه أنا النقطة حبيت أني يمكن أوضحها أكثر لأنها جدا مهمة.
وهذا زي ما تفضلت يعني بروف، يعني اللي تفضلت فيه أنه وجدت الأرضية جاهزة لهذا التحول، واللي الدافع لذلك كان إيمان الممارسين الصحيين وإرادة الدولة وإيمان المجتمع بأهمية هيئة مثل هيئة التخصصات تسجل جميع الممارسين الصحيين، بحيث تضمن أن المجتمع الآن مجتمع ينال الخدمة الصحية بمنتهى الكفاءة. وهذا انعكس يمكن وتوجه للبروف أيمن بهذا السؤال. مجتمع سمطنة.
اسمح لي في تعليق يمكن مهم جدا. أنا أشرت كذلك أبو نزار أشار إلى تحسن الوضع المالي. يمكن يتبادر الذهن أنه تحسن الوضع لأنه بدأ نأخذ رسوم تدريب وتصنيف، هذه ما كانت تغطي بالواقع حتى يعني الصرف على المدربين وعلى أعضاء اللجان. الهيئة نظامها مرن جدا جدا، وفي مادة يسمح لها بالاستثمار. فمبكرا لما تجمع عندنا شوية فلوس أنا بادرت وطلبت من مجلس الأمناء تفويض بأننا نستثمر بعض الفلوس اللي عندنا، وصدر قرار بأن الأمين العام مفوض يستثمر إلى حد 50% من أرصدة الهيئة، ومن هنا جاء الدخل عليه. وهذا اللي خولنا بعدين ومكننا يعني توطت الهيئة وبنينا المقر من الاستثمار، المقر بالرياض، وشرينا أراضي بجدة وبالدمام. بس هذا يعني أساس يعني يكون نقطة إيضاح.
وهذا صحيح، وهذا صحيح، وفعلا تشهد بذلك يعني يمكن اللي يرون تجربة الهيئة في هذا الجانب الحمد لله يعني من الأمور التي قادت فيها الهيئة ملف الاستدامة، وكثير من الجهات الآن تدعى إلى الاستثمار وتشكل لجان استثمار، وهذا أمر الحمد لله سبقت فيه الهيئة نظرا لتعقيد المنظومة الصحية، منظومة الممارسة ومنظومة التعليم اللي تتطلب كل العبء هذا للنهوض بأعمالها. كل هذا من أجل الوصول إلى مجتمع صحي بكفاءة، وهذا كان يمكن الرؤية اللي كانت في الاستراتيجية وقت البروف أيمن ووقتك يعني أبو عمر إن سمحت لي. توفيق ما بين دور الهيئة وهدفها الرئيسي اللي هو تطوير الأداء المهني الصحي والوصول إلى مجتمع صحي بكفاءة في مرحلة أنا أعتقد أنها من أصعب المراحل اللي تمرت على العالم على الأقل في العصر الحديث، اللي هي مرحلة كورونا. كيف لعبت الهيئة دور في تطوير الأداء المهني الصحي بسرعة وفعالية وببرامج نوعية، وكيف كان منظورها، وما هي القيمة المضافة التي أضافتها للمنظومة الصحية وللمجتمع في هذه المرحلة الحالكة باستخدام كل هذه الممكنات وبالمنظور الذي رسم وقت ترأسك لأمانة الهيئة.
بسم الله الرحمن الرحيم. حياكم الله جميعا، وشكرا إبراهيم على الفرصة هذه. التقينا بأصدقاء وزملاء وأساتذة كبار، فمسرور جدا. فترة كورونا ما سوينا شيء، قعدنا في البيت. في شيء سوينا ثاني؟ قعدنا في البيت والحمد لله الأمور زانت. الله يحييكم. أول شيء طبعا ما شاء الله اكتشفنا في عبد الله مدافر جديد، يعني أبو إبراهيم لك مستقبل في الحوارات.
ما شفت شيء.
لا شفت شيء؟ لا ما تقدر، خلاص في وقت محدد. فمهاراته متعددة ترى الأمين الحالي، بعدين يعني ممكن شاعر ما شاء الله عليه وأديب وعبقري من جميع النواحي. الحقيقة أنا تشرفت أنه أكون في هذه السلسلة المباركة، ولو تلاحظوا 2 جهاز هضمي وجراح جهاز هضمي، فأوضح لكم أنه يعني إيش، أنه هذه المهنة شريفة. اللي يمسك الهيئة بعد هؤلاء العباقرة والرموز الحقيقة من غير أي مجاملة، زي ما تفضل أبو نزار، يعني يمكن تكون مهمة أسهل. يمكن اللي في الفترة اللي تشرفت فيها أن أكون معاكم كان في يمكن 3 أشياء أساسية. أول شيء يعني يمكن بداية الرؤية المباركة. الرؤية طبعا غيرت كل حاجة. الآن أنت ما عاد صرنا عايشين في سايلوز، ما تستطيع تستفرد بالقرار، أنت جزء من منظومة. فيمكن كان من أهم الأشياء اللي كان لازم الهيئة تسويها أنها تبدأ تنفتح على النظام الصحي وعلى المجتمع الصحي. فيمكن هذه كانت يعني واضحة في الفترة هذه، أنه يعني التزامنا بالتحول الصحي وإيش دورنا فيه. فهذه يمكن تكون علامة واضحة. أيضا الانفتاح على المجتمع، يعني يمكن صارت الهيئة شوية مور يعني اوبن، وحتى كنا دائما يقول لك انه حفلاتكم كثيره وتصرفون فلوس في الحفلات وكذا، بس اتوقع انه هذا كان مهم انه الهيئه تكون اقرب للممارس، بسبب انه كان تحسن طبعا الخدمات الرقميه فصارت افضل. فيمكن هذه علامه كانت مهمه. الثانيه يمكن يعني ممكن نسميها corporatization، يعني يمكن في الفتره هذه حرصنا اكثر على البروجكت مانجمنت، ريسك مانجمنت، البروسيسز، الكواليتي ديبارتمنت، شويه يمكن تجذرت بشكل يعني مرحله مشت مرحله اضافيه شويه. بس حقيقه بكل امانه، وهذا ليس تواضع، والله ليس تواضع ابدا، انا ما اعتقد انه كان في انجازات حقيقيه في هذه الفتره. اللي كنت اشوفه انه في نمو وتحسن، وفي ملفات كانت حقيقه جيده ومميزه. يمكن اول واهم ملف كان زياره المقاعد مره اخرى، يعني كل واحد يعني يدف الكرة هذه زيادة. فإحنا يعني تقريبا المقاعد تضاعفت من حوالي 2700 إلى حوالي 4500. فحاولنا نكون بقيادتكم جميعا إنه كيف تسود المقاعد من المحافظة على الجودة، والآن ما شاء الله تبارك الله أسمع إنه وصلنا إلى 7000 وزيادة. فهي هذه السؤال إنه كيف تستطيع أن تقوم بهذا الشيء مع ضبط الجودة، هذه كانت يمكن مهمة. الثانية حقيقة يمكن كان في تطوير كبير في موضوع التعليم الطبي المستمر. حاولنا نطلع من إطار الساعات إلى إطار البروفيشنال ديفلوبمنت. نجحنا في أشياء وفشلنا في أشياء كثيرة، بس أعتقد أنه بدأت شوية مسيرة الفكرة أنه هي ما هي قضية تجميع ساعات، هي قضية مهارات وقدرات. فيمكن هذه تكون مهمة. يمكن الأكاديمية الصحية مشروع مهم جدا، وأعتقد أنه كان نوعي، وكان يعني هنا أنا يعني ما أنسى يعني أستاذي أنا ويمكن زميل لنا جميعا البروف العمران، الله يعني يمسيه بالعافية والسعادة. يعني أنا لا أعتقد أنه يعني خدمته ومشاركته للهيئة تقل عن أي واحد من الجالسين هنا، بل أنا أعتقد أنها تزيد عن حقيقة يعني الجهد المتواضع اللي سويته. أبو محمد كان هو اللي وراء الأكاديمية الصحية، هو اللي سعى لها وهو اللي أنجزها. الأكاديمية خرجت في ذيك الفترة حوالي 20,000 ممارس صحي كان عاطل عن العمل أصبح يعمل. موضوع التجسير، أعتقد هذا كان نقلة نوعية مهمة للهيئة. أكاديمية القيادة الصحية أعتقد كانت مهمة جدا، وكيف يعني أنها كانت ريسورس للمجتمع لتطوير القيادات. ويمكن عشان أنت تحب القصص، أنت ما تبغى الآن تقرير، تبغى قصص. فجاني اتصال من دكتور توفيق الربيعة يقول أبو عمر نبغى نحط ترخيص للقيادة الصحية، ما حد يمسك مدير إلا يطلع ترخيص من الهيئة. قلت له محمد ترى الناس كارهيننا كفاية، يعني ما نبغى نرخص كمان كذا. قلت له إيش رأيك الحين نسوي تدريب؟ يعني وكانت أكبر تحدي في الهيئة ذاك الوقت إنه أنت بين تحديين. التحدي الأول أين الهيئة من؟ يعني إذا ممارس صحي اعتدي عليه يقول لك أين الهيئة من الدفاع عن الممارسين؟ إذا في تخصص صار في بطالة أين الهيئة من الدفاع عن هذا التخصص؟ تغمض عينك تفتحها يجيك واحد يقول لك الهيئة تغولت والهيئة صارت تعمل كل شيء. الهيئة تدرب وتصنف وتختبر يعني. فهذا التحدي كان تحدي استراتيجي، إنه ما هو دور الهيئة الحقيقي. وأعتقد أن هذا يمكن في الفترة الحالية بدأ الحمد لله تشتغلوا عليه يا إبراهيم شغل جيد. ما تستطيع تفعل كل شيء أو تقوم بكل شيء. فصار في يعني تركيز على هذا الجانب. أكملنا النقلة النوعية في الاختبارات. أعتقد الاختبارات صار فيها تطوير جيد. المجالس المهنية وغيره. فأنا أعتقد هي ملفات انفتاح على المجتمع أكثر، انفتاح على التحول الصحي، وتطوير وتحسين وترسيخ وتدعيم للأعمال العظيمة والجهود اللي قام بها أبو نزار وأبو محمد وبقية هذا، لا أكثر ولا أقل. صار في شوية أيضا شغل، يعني بيئة الهيئة يمكن صارت أقرب، يعني يمكن صاروا الموظفين أقرب إلى بعض، وصار في لأنه يعني يمكن المجتمع تغير، البلد تغيرت، دور المرأة تغير، تمكين السيدات. فيمكن هتلاحظ الهيئة في الفترة هذه صارت شوية more like a community بسبب تغير المجتمع وليس بسبب أي شيء عبقري يعني إحنا سويناه. فمعتز بكل اللي أنجزتوه ومعتز بكل اللي سويتوه وفخور بكم جميعا.
الله يعطيك العافية أبو عمر. نرجع لموضوع الكورونا بالمحور الثاني، ما راح نخليه
خلاص.
إيه. يمكن
بعد هذه هتبدأ تحاسب، لأنه أنا الحين في القطاع الخاص 15 دقيقة مجانية والباقي بالحساب. ايش رايكم؟ والله صحيح.
طيب بروف، يمكن في المرحلة هذه وانت تنظر للهيئة على جانب آخر، يعني بعد مشوار الهيئة انتقالك إلى سلك التعليم أو قيادتك لجامعة، كيف شايف الدور اللي ممكن تلعبه هيئة زي هيئة التخصصات مع التعليم الصحي، ولا سيما أن التعليم الصحي يعتبر عملية معقدة مختلفة عن يمكن التعليم العالي في أي ديسبلين آخر، وفي أكثر من مشكلة فيها حقيقة. ارتباط التعليم، ليس التعليم ليس مقاعد دراسة فقط، ارتباطه بالبراكتس بشكل مباشر، التداخل ما بين التخصصات الصحية كلها اللي استدعى أصلا وجود هيئة لجميع التخصصات، والعمل اللي لا يمكن أي ممارس صحي ينفصل فيه عن الآخر، فلا بد أنه يتعلم مع بعض. كيف شايف دور الهيئة المستقبلي في ملف التعليم الصحي؟
الهيئة جت يعني في وقت كان البلد في أمس الحاجة لتعليم صحي. كان إمكانية القبول للالتحاق بالتدريب الصحي بالخارج كان جدا يعني محدود جدا جدا. الزمالة العربية كانت موجودة والمملكة كانت من المؤسسين مشاركين فيها أعتقد إلى حتى الآن، ولكن ما عليها أي ضوابط ولا تخضع شيء. طبعا التعليم الصحي يخضع لوجود منشأة صحية يتوفر فيها ناس عندهم الاستعداد للتدريب الصحي، ناس عندهم يفضل عندهم ناس خلفية أكاديمية خلفية بحثية، ومنشأة تكون يعني متكاملة الأركان للتدريب، وناس مستعدين، ويكون يعني العدد المقبولين يتناسب مع عدد الأسرة. وحنا تميزنا هنا أنه يكون في تقييم مستمر نظرا لظروفنا. حنا نعرف الشباب السعوديين إذا لم يكن في يعني متابعة ومراقبة يعني يكون يعني شوي يعني المتابعة والممارسة والتعليم والتطوير يكون يعني شوية، احنا انتابنا قبل شوي الهدوء والخلود. فاحنا نظام التدريب بالهيئة هو النظام الأمريكي الكندي، هذا متفق عليه من البداية يعني، ولا يزال هو اللي ماشي يعني، ولكن احنا أضفنا عليه زيادة بعدد مرات التقييم والامتحانات. وطبعا المجالس العلمية كانت هي، وأرجو أن تكون تزال أنها هي المسؤولة عن التدريب، كانت هي لها دور بالاعتراف بالمنشأة في مجال اختصاصها بعد ما يعترف المنشأة من قبل لجنة الاعتراف العامة. كانت تقيم وتحدد يعني نمط التدريب، عدد السنوات، عدد المدربين، وتشرف عليه. وفي لجان محلية تسند المجالس، ودورها يكون التقييم العملي المستمر للمدربين. في آخر كل سنة يقيم المتدرب، ويكون في طبعا ممتحنين خارجيين دائما لأجل الجودة يعني، وهذا مهم جدا جدا. وكان الحمد لله يعني متدربينا يعني كان دائما يعني يتمتعون بجودة ممتازة. أنا أذكر أنه يعني يمكن 2004 2005 رحتنا بمهمة لكندا، ومعنا كان وكيل وزارة التعليم العالي، ومرينا على تقريبا معظم مراكز التدريب في كندا. وكان ذاك الأيام في سعوديين يتدربون تدريب دقيق بعد ما خلصوا التدريب العام بالمملكة. وكان السؤال اللي يطرح على كل مركز دائما ما مدى يعني تقييمهم للخريجين السعوديين. فكان الإجابة تقريبا موحدة، أنه بعد فترة تأقلم شهرين ثلاثة تجد المتدرب اللي أخذ شهادته العامة من المملكة واللي حصل على تدريبه بداية بكندا لا يختلفون عن بعض، أول كندي يعني. وكان هذا بالنسبة لنا احنا مطمن الصراحة يعني. فكانت هذه الضوابط، واستمر العمل على هذا الشيء يعني. التدريب الصحي طبعا هو جله عملي يعني، ما هو يعني نظري، ما هو بيتم في قاعة محاضرات، ولكن التدريب النظري له دوره بالتأكيد، ولكن 90-80% عملي، مهارات، قدرات، كفاءة، تعلم يعني كيف تاخذ القصة المرضية وهكذا يعني. فهذا التعليم الطبي، واعتقد انه الهيئة يعني حصلت على إشادة من يعني جهات كثيرة. اذكر ان يعني في اختصار انه المجلس العربي كان يخضع لوزراء الصحة العرب، وكان لهم اجتماع دوري، وكان من بين المواضيع انه ما كان في رضا عن مخرجات المجلس العربي، ودعيت انا كزائر لا اكثر ولا اقل يعني حاضر يعني. فكانوا ذاك الايام فكرين انهم يطلبون من احدى الهيئات الملكيه، واعتقد انها كانت الايرلنديه، بانهم يقيمون وضع الزمالة العربيه ويطورونه. وقام رئيس اتحاد الطب العرب، اعتقد انه مصري او اردني، فقال يا للعيب يعني، احنا عرب ودائما عندنا نقطة الضعف، النقص. عندنا هيئة التخصص الصحية، أنا أشهد شهادة يقول كذا لله وبالله أن من أحسن الهيئات المسؤولة عن التدريب، فلما تروحون لإيرلندا وعندنا المملكة العربية السعودية؟ هل عيب أن نستعين بهيئة محلية؟ ومن هنا شكل لجنة كنت أنا عضو فيها للنظر في تحسين وضع الزمالة العربية.
هذا يعني هذه شهادة كبيرة حقيقة، واليوم البورد السعودي يشهد له شهادة عالمية، والحمد لله شهدت اليوم منصة توقيعات خلال اليومين الماضية، توقيعات كثيرة من ضمنها مع رويال كوليجز وكنديانز وغيرها، حابين أنه يكون في عدة يعني مشاريع مشتركة في منظومة البورد السعودي. فهذه غير طبعا يعني ريجنال وعلى عدة مستويات. هذا من جانب الدراسات العليا الصحية والتدريب الصحي. البروف عبد العزيز، خلفيتك الأكاديمية كأستاذ في الجراحة وفي كلية الطب وعميد سابق، ومنظورك من ناحية التعليم العالي، التعليم الجامعي على مستوى الطلبة، ومدى دور الهيئة في بناء شخصية الممارس الصحي على مقاعد الدراسة، ومساهمتها يدا بيد مع الكليات الصحية، كليات الطب والصيدلة وطب الأسنان وغيرها. هل ترى أن هيئة التخصصات لها دور ممكن تلعبه في هذا الجانب؟ وإن كان كذلك، من منظورك كأستاذ جامعي كيف شايف أنه هيئة التخصصات ممكن تساعدك في أداء عملك؟ أو كعميد كلية كيف شايف أنه هيئة التخصصات ممكن تدفع بالتعليم الصحي على مستوى التعليم الجامعي؟
أنا أعتقد أنه التدريب يعني في المستويات كليات الطب ما في شك أنه مهم، ما أحد يشك في ذلك، هو من أصعب المراحل على فكرة، لأنه في المراحل البوست جراد المتدرب هو مسؤول عن نفسه تقريبا، بينما في الأندر الطالب يحتاج مساعدة ويحتاج إشراف ويحتاج دعم من الجميع. أنا الحقيقة اللي أرى ويمكن تجارب نسمعها ويمكن حتى تجارب شخصية أبنائنا مروا بها أحيانا، عندي الحقيقة قلق كثير على التدريب في كليات الطب، ما عندي في ذلك شك. قد يكون في أسباب كثيرة ليس بالضرورة أن نذكرها الآن، ولكن أنا أعتقد أنه الطلاب والطالبات بصفة عامة اللي يدخلون كليات الطب ما نشك في ذلك هم التوب ستودنتس، ولهم رغبة ولهم يعني رغبة في التعلم وإصرار على التعلم. المشكلة أعتقد أنها تأتي في الكليات، ولما أقول الكليات هي ليس فقط في الكريكولم أو نظام الدراسة أو المنهج، وهذا قد يكون جزء منه، ولكن في أعضاء التدريس. أنا أعتقد في انصراف واضح للاهتمام بالطلاب من أعضاء التدريس، وإذا في سبب أنا أعتقد أنه موضوع القطاع الخاص والممارسة في القطاع الخاص. يعني النظام يعني أعطى فرصة للأساتذة بأنهم يعملون في القطاع الخاص، ولكنه حدده حقيقة، حدده بساعات وبأيام، ويعني كل المعايير لضبطه وضعت. المشكلة الرئيسية أنا أعتقد عدم الالتزام يعني بهذه المعايير، وأصبح الآن للأسف، وأنا كنت أعمل في القطاع الخاص، ولكني والله في الفترة اللي كنا نعمل فيها يعني كنا إن شاء الله نعمل بأمانة يعني، وأنا متأكد حتى الموجودين الآن يعملون بأمانة، ولكن اختلفت يمكن الطرق والمغريات. الآن أصبح الممارس رقم واحد اهتمامه هو القطاع الخاص، رقم اثنين هو يعني مستشفى الحكومة أو كلية الحكومة أو سمى اللي تسميها. يعني أنا أقول الكلام هذا بصوت عالي لأنه فعلا مشكلة ومشكلة ومشكلة.
طيب، هو يعني بروف عبد العزيز اللي أشرت له هو انصراف أعضاء هيئة التدريس وتوصيفك للمشكلة بأنه أعضاء هيئة التدريس هم حجر زاوية في العملية التعليمية وليس فقط المنهج أو الخطة الدراسية. فممكن يكون في دور لهيئة التخصصات بالالتفات نحو أعضاء هيئة التدريس في الكليات الصحية باعتبارهم هم في أساسهم ممارسين صحيين، وأيضا يمكن تقوية التدريب في مرحلة الجامعية لأنه جزء لا يتجزأ من المنهج الدراسي. وذكرت القطاع الخاص، ويمكن الآن أبي أسأل أنا أبو عمر باعتباره ذكر القطاع الخاص بروف، ولعل الواحد يشغل لنا عداد عشان بس نحسب ونفوتر لك يعني في الأخير. فالقطاع الخاص في ستيغما معينة، في منظور معين على القطاع الخاص، ولكن من واقع اختبارات هيئة التخصصات في عدة مجالات نجد بعض الكليات في القطاع الخاص والله تبلي بلاء حسنا يعني، وبعضها لا. وفي تفاوت أيضا في القطاع الحكومي كذلك الجامعات والكليات، في تفاوت في الاختبارات المهنية في الهيئة. ونلاحظ أيضا اليوم أنه فيه بعض التوجهات خصوصا في الاستراتيجيات الحديثة في تبني القطاع الخاص هو أنه يكون فيه استيعاب للعملية التدريبية داخل القطاع الخاص. مدى استجمة هذه صحيحة؟ أو صحيحة في وقتها واليوم ما هي صحيحة؟ هل فعلا القطاع الخاص شريك مثل ما احنا نتوقعه في العملية التعليمية وعملية تقديم الخدمة العلاجية؟ هل تشوف مستقبل للقطاع الخاص واعد في مسألة التعليم الصحي وردف الممارسة المهنية بتعليم صحي ممتاز؟ هل ممكن نجد أنه مستشفى قطاع خاص عنده برنامج تعليمي متميز هل شايف هذا في المنظور أم أنه المسألة لها جوانب إحنا مو شايفينها وأنت الآن تجلس على الجهة الأخرى من الطاولة؟
هذا سؤال ملغم، جاوب ولا ما نجاوب أحسن؟ ايش رايكم زار؟ ملغم. خلينا نتكلم بسرعة مرة، لأن هذا القطاع الخاص في صفر. أول شيء البرنسبلز الأساسية. الرؤية المباركة أتت لتمكين القطاع الخاص، فهذا خلينا نتفق عليه. ويعني واضح جدا في الرؤية إنه هذا الفاير وول اللي بين القطاع الحكومي والقطاع الخاص المفروض إنه يختفي. قصة إنه أنت حكومي وأنت خاص ما تجده في القطاعات الأخرى، في قطاعات الطاقة، في الزراعة، في الصناعة، في السياحة، ما تجد هذا التفريق المبالغ فيه. فواحدة من برامج الرؤية الواضحة هي تمكين القطاع الخاص. الآن القطاع الخاص في الممارسة يعني في الدليفري اوف كير حوالي كم 22%، الرؤية تتكلم عن 40%، يعني we need to double. طيب، فهذه المعلومة الأولى. المعلومة الثانية some of the best يعني training centers في العالم هي قطاع خاص، يمكن مو خاص بالمعنى الخاص اللي عندنا، كثير منها غير هادفة للربح، بس احنا دائما نغلط يعني نعتقد انه غير هادف الربح يعني هو لا يربح. غير هادف الربح يربح ويربح ويربح، ولكن المراد انه لا يوزع هذا الربح على مستثمرين وانما يبقى في المؤسسة. فميو كلينيك از برايفت، وهارفارد از برايفت، وجونز هوبكنز از برايفت، كلها برايفت. طيب كيف قدروا يوصلوا للشيء هذا؟ هذا معلوم يعني الحقيقة الثانية. فإذا كانت الرؤية بتحضنا على يعني دعم القطاع الخاص بالذات في الجوانب التعليمية، إذا كان وزير التعليم نفسه هو is a corporate leader جاي من شركة حكومية عظيمة، إذا كان تجد أنه الكوربراتيزيشن في الدولة يعني أيدها الله واضحة جدا، فأنا ما أعتقد أنه في خيار. فأنا أعتقد السؤال ما هي التحديات. أما أنه إحنا نيجي نقول القطاع الخاص لا يستطيع أن يدرب، هذا أعتقد أنه تجاوزناها. طيب، فهذه رقم واحد. هل القطاع الخاص حاليا مؤهل لتدريب ريزيدنس؟ لا، هذه ما يبغى لها تفكير. يعني مثلا أنا ممكن أكون طبيب مميز، عيادتي في الليل، هذا الريزيدنت هيجي يقعد معي في الليل من 5 إلى 9 في الليل. ثاني يوم الصباح الريزيدنت هذا عنده عملية، بده يجي يسوي العملية في الليل، في الصباح الريزيدنت خلص الروتيشن حقه إلى آخره. فوضع القطاع الخاص حاليا غير مؤهل لتدريب الريزيدنت بالشكل الكبير. لكن ما الذي نحتاج أن نفعله؟ ونحتاج أن نؤهله، نحتاج أن نساعده. فالقطاع الخاص يفكر في 3 أشياء. أول شيء ما هو العائد أو الخسائر المالية. الآن أنت تطلب من القطاع الخاص أنه هو يفتح مقاعد ويدرب ويدفع رواتب، ما هيسوي كذا. يعني كثير من القطاع الآن يعني يعاني. شايفين أنتم الآن المستشفيات، يعني أنا حقيقة أقول لكم بأمانة، الآن لما صرت داخل القطاع العملية ما هي بالسهولة اللي الواحد كان يتوقعها من برا. كان يتوقع إنه هذول كلهم بيعملوا ملايين وملايين. There is a real struggle. فإني أطلب منك إنك تدرب 300 طبيب مقيم وتدفع رواتبهم وتهتم فيهم، ما هيحدث. فالسؤال اللي ما هنجاوب عليه الآن اللي هو ما الذي نستطيع أن نفعله لنمكن القطاع الخاص من زيادة فرصه التعليمية أو التدريبية. فهذا بالنسبة للتدريب. بالنسبة للكليات أنا أختلف. الكليات أعتقد تعمل كويس. يعني في فترة اللي احنا كنا فيها 2 أعتقد ورا بعض كانت كلية خاصة هي رقم 1 في اختبارات الهيئة، وكلية يعني مميزة جدا، وأعتقد أنه هذا وارد وممكن جدا. فنفرق بين الأندر جراديويت، أعتقد الفرص ممتازة ومتاحة، ومعالي وزير التعليم الحالي والسابق، ويعني في دعم كبير جدا والتقينا فيه كذا مرة، يعني دعم مفتوح للكليات الخاصة. تدريب البوست جراديويت في تحديات، لكنه أعتقد أنه ممكن تجاوزها، ودور الهيئة كبير جدا في أنه ممكن تذلل هذه العقبات. فهذا الجواب العام. يعني
تفضل.
يضيف إضافة، أنا قلت أن التدريب يتطلب دائما عضو تدريس كفو ونشط وقاعدة تدريبية. القطاع الخاص في مرضى خاصين. احنا لما كنا بالمستشفيات الحكومية دائما في معاناة مع إقناع المريض أن يخضع للتدريب، يخضع للطالب يفحص عليه. فالقطاع الخاص الوضع يختلف، يعني صعب انك ترغم مريض او تخضعه او انه يعني يخضع نفسه للفحص الطبيعي الطالب، يعني ما المريض ما يبغى يعني. فهذه مشكله صراحه. صحيح انه توفرت الحين اجهزه المحاكاه يعني تعوض، ولكن ما اعتقد تغني ابدا عن المريض الحقيقي يعني. وهذا المشكله الان يتعلم منها الكليات اللي بالمدن الفرعيه. لما توسعنا في التعليم الطبي في مدن يعني زي نجران وحائل، وهذه اعتقد انه يعني فعلا هذه كانت مشكله كبيره. هذا اللي اعتقد مخرجاتها يمكن هم اللي يعني يعانون شويه. اما الكليات الكبيره اللي عندها مستشفيات فوضعهم يعني يختلف.
هو نظريات التعليم الصحي كثيرة وتدور حوالين يعني عدة أمور، وإحنا ودنا والله إنه يعني نناقش يعني هذا في أكثر من محور. هذه جلسة الأمناء الحقيقة جلسة ثرية، وكثير من الممارسين الصحيين يعني ينقلون تحاياهم لسعادتكم، وكانوا حريصين جدا يعني على حضورها، وفي بث مباشر هم يشاهدونه. فالحقيقة نأمل أن تعيدون بتكرار مثل هذه الجلسات من حين إلى حين وفي أكثر من محفل. السنة هذه احنا نحتفل حقيقة يعني بمرور 30 عام على البورد السعودي. أول برنامج أطلق سنة 94، واليوم كملنا 30 سنة، عندنا أكثر من 170 برنامج. فالحمد لله رب العالمين يعني عدد كبير من الخريجين تجاوزت يعني أعدادهم يعني عشرات الألوف من حملة شهادة البورد السعودي، بما فيهم أيضا يعني من غير السعوديين اللي حصلوا على هذه الشهادة. وفي إقبال كبير حقيقة للدراسة في برامج البورد السعودي والاستفادة من خدمات الهيئة الكثيرة. شاكر جدا لكم وقتكم، شاكر جدا يعني مساهمتكم في البرنامج اليوم، برنامج هيئتكم حقيقة، وشاكر جدا على نقل هذه التجربة والحديث عن هذا التاريخ وعراقة هيئة مثل الهيئة السعودية للتخصصات الصحية، وتصدير هذه التجربة للعالم التي إن شاء الله ستكون تجربة رائدة تضعنا على مستوى نصدر فيه تجربة سعودية بطراز عالمي، وبحول الله ترون الهيئة من حسن إلى أحسن بإذن الله. شكرا جزيلا وشكرا للحضور.
السلام عليكم، مساكم الله بالخير. أنا عن نفسي exhausted What about you guys? اللي تعبان يرفع يده. طيب تصفيق حار لكل اللي موجودين، الله يعطيكم الصحة والعافية. شكرا أنتم نجوم هذه الايفنت والفعالية. أوعدكم أنه I'll cut to the chase. I'll be quick. I'll deliver 3 key components. النقطة الأولى حنتكلم عن المبادرة البحثية أو research grants. And my apologies, I probably should switch to English. So I'm going to talk about the research grant. Number 2, I'll talk about the data services that will support that research grant. Third, we will talk about how to move forward, how to actually apply and submit. All right? So thanks to our esteemed guests who gave us a great brief about the history of the Saudi Commission. So I'll skip this part. I'll only highlight that since 1992, the Saudi Commission mandate was to support research since that day. So it's been part of the core of the mandate of the Saudi Commission. Moving forward, since they gave us a lot of history lessons and very valued stories, I'll go to today's. As part of the new strategy of the Saudi Commission, and also in accordance with the national direction of supporting research, development, and innovation in Saudi Arabia, the Saudi Commission started to build the new products. Categorically can be split into 2 categories: supporting research activities within the Saudi Commission, so the employees of the Saudi Commission, and support research activities for the members of the Saudi Commission, healthcare practitioners, healthcare practitioners and health students as well. So today we were going to focus on this part as alone. One challenge in this regard that we wanted to create a scalable approach, because the initial approach was creating a list of the problems, then just come here and tell you about these lists of the problems, kind of research questions, and you guys can come up with research answers and methodologies and do that. But we feel this is not good enough. This is not scalable, and this is very limiting to your skills, set of skills and creativity, and we don't want this. And it will be redundant work. Every time we will create a set of problems, then we'll create another set of problems, and we create another set of problems. It's tedious. So what we thought of, how about we create a research support opportunity with our strategic partner, the Saudi National Institute of Health. To do this, we needed to create and define research challenges for the Saudi Commission. And to do this, we had lengthy interviews with the leaders of the Saudi Commission. We consolidated all these, the results of these interviews. We created themes and sub-themes. They call them tracks. So themes and sub-themes of research problems, and clear identified a view of what we need and what we consider as research challenges. Then we will leave the rest to you. You come up with the research questions, and we'll show you examples of how to do this. So what we came up with, 3 research tracks or perspectives: the practitioners, the institution, and also the curricular and education. So every problem, now you look at it, you can look at it from 3 angles, whether from the practitioner perspective, whether from the organization perspective, and whether from the curricula and program perspective. And we need you to think that way and to take off the day-to-day practitioner hat. So you can create a research about comparing paracetamol and aspirin and treating headache, for example. That's a very fascinating research, and I think it's important. But it's not part of our research problems and strategic challenges that we need to solve at the Saudi Commission. So we need healthcare practitioners to think differently, to look at things the way we look at, so we can work together to solve these problems. Let's take an example here for the healthcare practitioner perspective. What we focus on, for example, and by the way, we created a long list of sub-problems or sub-themes, and we went to the leaders of the Saudi Commission, and we actually made them vote, and they voted. And this is the result of their vote, those top three problems. And interestingly, His Excellency, the Minister of Health, yesterday, he was highlighting some of the major problems in healthcare worldwide, and one of them is workplace burnout and stress among healthcare practitioners. So I think, and someone, he just nodded, they heard it. So I think the leaders of the Saudi Commission, we were right spot on when they identified these problems. So think about how can you produce a very interesting question through these examples, whether it's a burnout and the effect, and I think you guys will be interested in this one. The Saudi Commission is very interested to know what do you think about their decisions, how they impact you, what is your perception of these decisions. This is the floor to you to ask these interesting questions, and we will actually help you to answer these questions in very transparent format. And we need you to publish it, by the way. Second example, organizational. So think about the organization as an ecosystem. So education system generates students that goes to the training and workplaces and on and on. So how these things are interlinked to each other. Where is the bottleneck? Which one actually can be improved and feed its output as a better input for the next step? These are kind of interesting. What kind of policies and procedures that actually we can study to improve? Where are the gaps in these policies and procedures, and etc. So now you are wearing the hat of the organization. We need you to think like that and ask these tough questions, and we're going to, again, help you to answer them in the data part, and hopefully you get lucky to find an interesting answer that we can implement. Third, the educational and curriculum. Now in Saudi Arabia, as you just saw in the whole theme of this event, future. What is the future of healthcare? What is the future of healthcare practitioners? What do we expect from healthcare practitioners of the future? How can we use technology to enhance the training, the education, the evaluation, and the continuous learning of the healthcare practitioner? How can we make you more suitable for the need of the future? These are very interesting questions, and the leadership of the Saudi Commission would like to know how can we move forward in this regard, and we'd like to know to get your input in this regard. This is an example. It's actually made by one of my colleagues at the research center, and I will give it 30 minutes of silence so you can all read it and to see how we think of these research proposals that we expect to receive from you. Okay, if you follow the bold lines, I think you got the idea. It's about measuring the burnout across different regions. Something like that, something in that notion, we expect something in that regard. Okay, so talking about how we can do this. What are the enablers to help you to do such a research? We try to get high view of what the data look like, and I'm very happy to have my colleague Khalid Al-Garni, the head of data analytics and AI. So if we have few minutes after this presentation, we'll be more than happy to answer any specific question about the availability of certain type of data or something like that. So we have more than 650,000 practitioners' information, and this information is being improved and validated through the integration of ecosystem of other partners in the healthcare and the ecosystem. So the information we have is not only produced by us through the cumulative data collection and the services provided, but also from our partners in the ecosystem. So we have these information, we have memberships and boards and many other information that you can be interested. Again, thanks to the data team, they give us a very simplified high view of the data warehouse that we have at the Saudi Commission. So we can again look at this. And the reason for us to explain and show this to you, so when you formulate your research question, you need certain type of data to answer them, of course, right? At least the secondary data. So this is what the data looks like, so it can help you to actually picture better imagining what is the research question that you should ask. So we have post-grad information, people information, establishments information, and if you look at the people, the people will wear different hats, whether they are trainees, whether they are practitioners, and within these information, you will find more specialized information. I'll take this view as more maybe self-explanatory graph. We plan to create a catalog. That catalog would help you to navigate through the data we have through 3 lenses: people, places, and programs. So if you look at the people, we have an essential table of information of the people. So we have their essential age, gender, location, etc. Then we have a specialized information depending on the hat they wear when you ask the question. For example, you are a practitioner, you have a license, but you are a student, a trainee, and you are an examiner. So you have different personas. We call them hats. We think hats are cooler than personas, so we call them hats. And that's because of the Saudi Commission itself. As they just said, there is few organizations in the world actually mimicking the same concept the Saudi Commission, where they actually wear different hats. Those are the ones who are helping you in the examination process and evaluation and et cetera, et cetera. So your data has to reflect that wearing multiple hats. So again, if you look at the organization could be a place of work, could be a university, could be a training center. So with every database, with every type of data, organization, for example, we have essential information. Then again, if you're asking about this organization as a workplace, you'll have a set of information that is different about this organization if you ask about it as a training place. I hope that clarified what the data looks like. And please, if you have any question in this regard, feel free to ask. Now, I'll move to my colleague, Dr. Msaad al-Shammari, to help us and shed some light about how to apply to this grant.
السلام عليكم جميعا الله يعطيكم العافية. It's صراحة very hard to come over دكتور عبد الله ما شاء الله عليه. دكتور عبد الله صراحة هو اللي who has this idea. It's very very fantastic idea. I think إنها first idea or collaboration between Saudi NIH and the governmental entity like the Saudi Commission for Health. إن شاء الله إنه يعني will success in future. So they told me no presentation will يعني إن شاء الله will take 10 minutes. Now 2 hours. So دكتور أيمن عنده حسابة إحنا ما عندنا حسابة. يلا كله for the science إن شاء الله. So the process of the submission, it's inshallah very easy. So the Saudi Health Commission will set the tracks, the 3 tracks as Dr. Abdullah mentioned, the one for the practitioner, one for the institute, and one for the policies and guidelines. For the Saudi NIH, our part will be responsible for the submission, for accepting the proposal, for reviewing the proposal, also dealing with the applicants with easy platform. So in the platform you can find all information you want related, all information that related to the opportunity. So start with the eligibility. So all PhD holders or equivalent can submit to this opportunity, whether Saudi or non-Saudi, from all institutions. And next slide, please. هذا أنا حاطه في حاطه في جيبي للريموت. I thought إنه this one for the mic. Back. Yes. So the budget for the opportunity, so we don't have budget for the opportunity, but the budget will be the resources provided by the Saudi Commission for the researcher. The data will be given to the researcher as a resources to do the research. Also, if the researcher publish a paper in any indexed journal, they will handle or they will cover the tuition or the fees of the publication. So inshallah in early December we'll post the opportunity on our website. Now we will open a link for the survey to get the interest. If you are interested, just write your name, your institution, and the idea that you want to submit for this opportunity. Inshallah, early next year, we'll open the submission for the full proposal. it shouldn't take a long time. By mid of next year, inshallah, we'll announce the winner for this opportunity in all tracks, in the 3 tracks. So this is how to evaluate based on the originality, based on the integrity, based on the soundness, linking the proposal to the opportunity tracks, and so on. So this is the QR code that will direct you directly to the survey. If you are interested, just go ahead and scan this QR code and submit your interest. And then you can register in our platform, grant management system platform, write your information. Inshallah, once we open the application, once we open the proposal submission, you can submit your full proposal. This is the GMS, the grant management system, the platform that we want to use it to handle this project, inshallah. It's easy. Just go ahead, log in using any email, institutional email, or whatever email, Hotmail, Gmail. You can log in, write your information, and after that, upload your proposal. This is the submission process. It's very easy. Once you log in, you can follow the directions. And yes, that's it. This is what we have. Thank you so much. Inshallah, we'll see a good proposal for this opportunity.
يعطيك العافية دكتور. Would you mind to switch back to the... Okay. ثاني يسوون تصوير. Okay. So those who are interested, feel free to use the link to go and apply. It's very simple questions. Your information, and we will contact you for further information, how to move forward, how to proceed. So basically, as Dr. Saad mentioned, we will have a webinar to explain all the future steps, how to move forward. So before we conclude our day, do you have any question regarding this initiative? Okay, I'll ask myself a question. How many research ideas we are supporting? Yeah.
How many researchers you support? You support the research idea. You will pay for the researchers. We will handle the submission. So the idea in all track.
Yep.
In all 10, I think.
That's exactly right. So we are supporting.
But not limited to 10. Maybe we received good ideas, so we can increase it up to 20.
Inshallah,
or 30.
with minimum of 10. Let's put it that way.
Yes.
So inshallah, we will support 10 great research ideas. Then we will take you to the next step, where we actually sit with you, identify the data that you need. We extract the data, and we will provide 3 types of data: either secondary data, which is from our database, or primary data by helping you to send surveys. We have our own system in place, so we can identify the sample, the population, and take a sample from it and send surveys, whether through emails or SMS. Then finally, and thanks to our marketing and media team, they actually give us a third option, which is the media sensing units. So basically, they can help you to listen to Twitter and some other social media platforms and get some notion of what are the main problems? Are they happy with this? Are they not happy with that? Then you take this data and you analyze it and you get back to us with some results, and hopefully you can publish that.
Inshallah, will allocate fund for, as I told you, Dr. Abdullah, from the NIH. Inshallah, will allocate good fund for the project or for the winners. Inshallah, it's a good idea. No one يعني فكر فيها من أول. Inshallah, إنه will success. Inshallah.
Inshallah. With this we conclude. Thank you very much. شكرا دكتور.